Holy Quran. I'm going to invite Mustafa to recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير مفتون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم.
Jazakallah. So welcome everyone. Welcome to the first international SIAG Third Space Advanced Endoscopy workshop. We are very excited that, as always, SIAG has taken this initial initiative to become the first one to introduce advanced endoscopy and a third space, advanced endoscopy in Pakistan. And we are very fortunate to have excellent international faculty. We have an excellent program for you today, which consists of 12 cases and which would be covering nearly all unique cases. And I'm sure you all will have an excellent opportunity not only to see these procedures and see the experts doing these procedures. So let me welcome our international faculty for this course. We have with us Professor Khalid Hassan, a renowned interventional gastroenterologist. He's director of interventional endoscopy at Advent Health, Orlando, Florida. And thank you very much, Dr. Khalid. And then we have Dr. Mustafa Rai. Dr. Mustafa is, again, an excellent endoscopist, interventional gastroenterologist, and he's an excellent teacher as well. In fact, both of them are very excellent teachers, and we just saw them, in the US workshop, which just concluded yesterday, and we had a very good feedback from all the candidates, and they had a great time and a great learning experience as well. So thank you, Dr. Mustafa, for coming. And then we have Dr. Farooq Khan, who's from King's College in UAE. We have national faculty members as well. We have Dr. Shahzad, who is from Shifa International. He's also an interventional gastroenterologist. Thank you very much, Dr. Shahzad, for taking out time and coming. And without much ado, now I would like to invite our international faculty, Professor Khalid Hassan, to please come and give a brief introduction of this workshop.
Assalamu alaikum. Thank you, Professor Sajda, for the kind introduction. This is the first third space and advanced endoscopy. We do advanced endoscopy before, but adding a third space and ESD and those are for the first time we're doing this workshop here. There are multiple cases. We'll have home cases for eclasia. We will have ESD as well, EMR, cholangioscopy, and cyst gastrostomy. I think there is a case for EOS-guided GJ as well. We will have at times 2 or 3 rooms running, but we'll show all the critical parts of those cases. And so it's a really honor and privilege that we are able to come here. And every time we come here, it's such a joy, and it's a way of paying back to our own homeland. So thank you for having us and treating us and feeding us and making us fat. And so I appreciate all that. Thank you.
Thank you very much, Dr. Khalid. Now I would request our coordinator for the course, Dr. Asim, to present the first case.
So We have divided the program into 3 sessions. Our first session would include 4 cases simultaneously. It will include a poem to be performed by Dr. Farooq, colonic EST to be performed by Sir Khalid Hassan, and chronic pancreatitis knife case to be performed by Dr. Mustafa, and a case of amphilectomy again to be performed by Dr. Khalid Hassan. So we will start with the EST case. She is a 80-year-old female presented to us with bleeding PR. Recent colonoscopy performed at a private hospital showed multiple polyps, polypectomy performed. There was a large rectal lesion, EST performed, and it showed high-grade dysplasia. There was another lesion in the ascending colon, again 3 to 4 centimeter in size. That's being planned for EST today. MRI and CT abdomen shows no invasion. So this is the case for EST. So this is her, if we can shift the screen. आपको remote से करना पड़ेगा ना हाँ image दिखा दें बस एक दफ़ा. So this is her last colonoscopy report. Most of the polyps were removed, but this was the lesion in the ascending colon that's planned for EST today. It's around 4 centimeters. Room ready? A moment, Dr. Khalid को ले जाएं. पीछे करो, इसको बंद कर दो. मैंने अपना उसमें डाला हुआ है. मेरी पावर पॉइंट खोल दो. ये खुला हुआ है ना, ये वाला खोल दो बस. currently a case of 4 years. Recent worsening for last maybe 3 or 4 months. Her ICART score is around 7. Endoscopy performed showed a very tight GOJ at around 42 centimeter with dilated esophagus and some tertiary contraction. The manometry was consistent with outflow obstruction with an IRP of around 47. Yeah, so but the pattern was possibly type 2 like. So she's here for poem procedure. Dr. Farooq, would you like to share some tips regarding poem till we start?
Assalamu alaikum everyone. Poem really is a relatively newish technique. It's a third space. It's taken over by and large. Oh, sorry. So poem is relatively a newer technique. In the last decade or so, people have picked it up, but this is considered one of the safest third space intervention, to be fair. And now it's really going easy on and on with quite significant success rate and low complications. But it's a third space. And the technique is really based on tunneling, largely, and then a myotomy, which is all done either posterior or interior. In our center, our experience is largely around posterior, which we will talk you through as we go along. Types, there are 3 types of achalasia. We normally, if you ask me which is the best achalasia type to have a poem for, it's type 3. It really is. But type 2 or type 1 as well. We do this is quite a doable thing, really. Problems, type 1, I think one thing that people should really know, you can dilate, that's fine, for type 1 particularly. But I think every time you dilate the patient, the poems become a bit more challenging. That's all, because you get some fibrosis, you get. As far as you guys are concerned, I think history is very important. Regurgitation, heartburns is just not reflux all the time. So endoscopy, as well as some manometry in the earlier assessment of your patient is very useful. It really is. It gives you at least some idea, if not confirmed. When we'll do this, I'll show you the technique. I'll talk you through about the technique as well. It's all submucosal injection and tunneling. So we're basically walking over the muscle, reaching the GOJ. We go past the GOJ about 2 to 3 centimeters, and based on what myotomy length. In our center, we use endoflip. We've talked about this. Had I known, I probably would have shown you some images for about 10 minutes on poem and things. I still have it if you want to during the course of the day. We'll show you some endoflip images too. So endoflip kya karta hai? It allows us to assess the exact amount of myotomy that we need to do. Because one of the criticism of poem was that you're cutting the gastroesophageal junction, right? So by definition, you are making the esophageal sphincter lax. So patient will have reflux. And the other argument against this was if a surgeon will do it, he will do the Hellers and he'll do the wrap at the same time. So not only he's treated the achalasia, he's prevented patient from reflux. And that, of course, has become a point of discussion in the recent years, that a lot of patients, they are coming back with reflux, because if you really think about it, you are giving him a lax lower esophageal sphincter. What poem allows me to, and this is then looked into, that people are doing much deeper gastric myotomies, right? So normally, if you don't have endoflip, don't worry about it. You could still largely about 2 centimeter gastric, then LES, and then you come up to decide what the myotomy is. With type 1, the myotomy really shouldn't be more than 5 to 6, if I'm being honest. There are studies that tell us that the length of the myotomy doesn't decide the outcome of your patient. You can have a very controlled 5 to 6, 7 centimeters myotomy, and they really are more than enough. And in our center, certainly since the last 2 years when we started using endoflip, we now bring the patient back at month 3 and at month 12, and we do one of the pH studies. And so far, we've had about 10 patients who've gone through that 1 year post poem, and the pH impedance studies do tell us that reflux is not a major issue now. because we ascertain the length of the myotomy. Training, I think, is useful to talk about, because hopefully what we were hoping is more and more centers in Pakistan will start this third space. And largely, you have to be a good endoscopist, have been able to do good numbers of AMRs, at least level 3 polypectomies before you start doing ESDs and POEM. Normally, preference is about 20 ESDs before you attempt your first POEM. When you do that, there are courses on animal models which I'll encourage you to go to. We have started one in UAE. We did our first one, which is animal based, 31st March this year. We might do another one later this year, or at least once a year we are hoping to do third space kind of an animal model course. So do try that. This will be useful here. Also go on the third, not just the workshop, but do some sort of training on the animal model first. And the other thing, it's not much different to a third space technique where you lift, you bleb, but it's just the fact of submucosal space is different to AMR. AMR is quick, short, you cut through. How many cases one should do before they go and do the POEM? I would certainly say at least you need at least 10 cases that somebody watches you over the shoulder, if doesn't take the scope from you, before you actually feel that you're independent. The paradigm is of 30 cases. You really need to have done 30 cases before you consider yourself that you should or can do independent. Even then, have a mentor on the phone if not in the same building. Because these are risky procedures. Patients bleed 1 to 2%, and that's not a small risk of bleeding as well as perforations. So it's not for faint-hearted. There's no doubt, but then it's very rewarding. It's like ERCP. It's like any other advanced endoscopy. So training paradigm is not really difficult, and it's very satisfying for the patients. And how do we prepare patient for this? Normally, I would suggest that at least, certainly, no matter what you do, we put them on liquid diet for at least 3 days, if not 5 days. They just go on liquid diet before the procedure, and 24 hours before the procedure, they just go on a clear diet. Yakhni, water, that kind of a thing, really. Apple juice, but as long as it's clear. They can have kava, they can have a green tea. After the procedure, the day of the procedure, we don't feed them anything at all. Next morning, we do the barium swallow. So gastrographin largely, not the barium. And we look if there's a leak. If there's no leak, then you start the patient back on the feeding oral diet for at least, we prefer 48 hours, just on liquid diet. Then they go on a soft diet for 3 days, then back on the normal diet by day 6, day 7. The other thing before the procedure is try them on high dose PPIs. Spanish centers, they put them on 5 days of fluconazole because of the inflammation, the antifungal and things. They think the inflammation. And I think this is fine. I have started using this recently, but I still don't put all the patients on antifungals. If I've done the pre-procedure endoscopy, it doesn't really look that inflamed, then that's okay, as long as they are on Nexium. Post-procedure, we certainly leave them on a PPI for at least 2 weeks. At least 2 weeks. The clips which we put them, they just fall off. You don't really have to worry about those. What are the things that you do have to keep in mind during the procedure? Mediastinitis. So inflammation, patient will get a lot of pain. They can get a CRP. It's not harmful to put these patients on IV antibiotics at least for the 24 hours. Okay? You do the blood test in the morning, you see the CRP and everything's quite high, then you know that this probably is mediastinitis. Pneumothorax is less than 1%. That's another complication of it. This is why we use CO2. Surgical emphysema is very common. It really is very common. So is pneumoperitoneum. And most of the time, you're able to deal, if you see the stomach is going, we'll put a needle. I think some of you who have seen us doing the point, we have done one here as well, where you just needle the tummy in the cavity with the water seal on it, and you just continue the procedure, you finish it off. Surgical emphysema, by and large, it resolved by next day. You're doing third space. Full thickness is what we're looking at. So you really see the serosa at the end of it, particularly at the GOJ. Some authorities do recommend that you extend that full thickness to the top. I don't normally, and the reason for that is, above 35, if you cut the circular layer, the longitudinal layer of the muscle, they really are not so tough or so stiff. And you will see that actually you might get to see this live as well. As long as you've done the circular layer, the longitudinal layer will start splitting themselves because there's a stretches now coming. But GOJ, you really will need a full thickness. You've got to have to go through longitudinal as well as circular muscles. What are the other techniques one can use to avoid reflux? Sling muscles. If you see them, I don't think patient will have much difference to their eating if you cut the sling muscles. So you can avoid them if you can. So these are the techniques. I'll probably will talk you through it as we go along. Definitely, definitely. Definitely. So on the endoflip, there's white lines that you see. So each white line is 1 centimeter. So as it goes along. So before I actually do, I know what type of myotomy I'm going, how long the myotomy. The second thing is, and I do endoflip during procedure as well. Once I think I've done what I needed to do. And if that endoflip has shown that the DI, which is descensibly indexed, if it's too tight, it's low. If it's better, it's fine. So for reflux patients, it's generally about 6 because it's very loose. For your achalasia patients, 0.8, 0.91. So what you're looking for is in between somewhere 3. Yeah? So if you got 3, then that's fine. So I do endoflip during the procedure as well. And if I know that it's reaching up to 2.5 to 3.5, anywhere there, then you really are fine. There's no need for us to keep cutting the myotomy either proximally or distally. You've achieved it. So endoflip has really changed the way that we have now managed achalasia. And G-poem. G-poem. Of course, gastroparesis is a very quick thing. In our center, how do you tell that whether is this patient has got global gastroparesis or actually it's got more of the antral or pyloric? So symptoms. Anybody, what's the symptoms of gastroparesis? What are the symptoms? What are the gastroparesis? Right, so nausea and vomiting. So 3 types: nausea and vomiting, bloating. Number 1, nausea, vomiting, bloating, pain, and bit of a nausea. So these patients very less likely to respond to any intervention. These are the largest group. But my job is to work out who's going to respond to G-poem and who that you need to put the pacemaker in. And that's important. Some people use symptom-based. So when you have more pain with nausea, then you probably have got pyloric sphincter involved. So maybe reasonable. But now we moved a step ahead. We do Botox of the pylorus. If the Botox have given you good response, then you know these might going to benefit more with the G-poem pylorotomy. In our center, we of course use endoflip. Again, if endoflip tells us the DI is very low at the pylorus, they go first for G-poem. And if that doesn't work, then they go for gastric pacemaker. Yeah? So that's just one of the ways we look at it.
Does Botox affect your G-poem?
Yes, I think I had only one patient who was referred to me from other center because they have a good response to Botox, but after 6 weeks out of gastroparesis, we're talking.
So the cause fibrosis will be So what are the causes of recurrence of symptoms in case of any recurrence after dysphagia? What are the options?
Can we do re-poem? I certainly wouldn't send them for balloon dilatation afterwards. So you can do re. The recurrence of symptoms after poem is not.
No, I was just going to answer the Botox.
Yeah.
So Botox, I think is a good indicator actually. If the patients respond to Botox, they might have a better response to G-poem. So G-poem, after the discussing it or not, you can do along the greater curvature and you can do it along the lesser. So usually majority of the time we do along the greater curvature.
Me too. Great.
तो अगर Botox किसी को करना है but what Botox is, it can cause some fibrosis. Yeah, it can affect to some extent, but you can get a problem. That should not be an issue. But if you think like patient is going to be a good candidate for G-poem in future, whoever does it, just find out what approach they use and try to inject the Botox on the upper ताकि अगर वो fibrosis का causes of fibrosis are still it should not be a problem.
True. So in our centers, We use endoflip, so we've moved away from Botox. But of course, in a lot of centers, they're still using Botox, and then they get referred to. So I think that's a very good solution. I always do greater curve, so you start from greater curve and you get. So yes, if you are doing Botox, I think it's which is easy to do, honestly. Botox is relatively straightforward. Then you do it so probably you want to do it at 12 o'clock, and I'm very happy for you to do something at around 3 o'clock. That's the lesser curve. This is your pylorus, so 12 at the top and 3 on your right hand side. Because when I will do the greater curve, I'll start generally from 6 o'clock and the tunnel will go towards 7. And all my muscle pylorotomies are generally at 7 o'clock. So you can do it if you were to do it. Response rate. So GPOIM studies have compared head-to-head as well as placebo with Botox and GPOIM. So I tell my patients from the very first consultations. I have 2 patients who, one had a GPOIM first and then had a pacemaker, and then a second patient who had a pacemaker done in States, and then she moved to UAE, and then she came for GPOIM. So combined or one on its own, the response rate is meant to be about 70%. And you need to tell your patient this. No matter what, there will be at least 3 patients out of 10 who will not see a response or a bare minimum response. Number one. Number two, the other thing that you need to tell your patients, you are not looking for complete resolution of a symptom. That is not the starting point. What you want them to do is at least their weight loss stops and they're able to sit down with the family and have a meal. They may not finish all of it, but at least they get their chair back on the dining table. That's really what the idea is. It's not about, so GPOIM, gastroparesis is less rewarding for patients as well as for clinicians. So if this is something you're looking to get into, don't be surprised. Any questions? No, we're talking about the effectiveness. Poem, any questions? Which centers got motility in their units? We have motility lab? Okay, and what do you do in there? pH?
We basically do visual micrometry and we have 24 hour pH.
Acha. And this is the impedance catheter?
Yeah.
You do Bravos?
We add the pill capsule but currently it's not.
But yes, this is right, okay. And rectal manometries?
The plan is running that.
Fine, okay. SIAG has got, यहाँ पे तो है
Manometry.
manometries. Any other centers who are doing motility work? Sadiq, your center? Do you guys do motility work?
I don't think so. This is not necessarily of system on this.
No, there's no do that. Oh, thank you. Do that. I think motility is certainly, if you want to do third space, motility comes really hand in hand. And this is a very underfed part of gastroenterology. So we are on the 6th of October, having the UAE and so King's London and ESNM, which is the European Motility Group. We're having our first conference in UAE, in Dubai, on the 6th of October. You're more than welcome to come. And what we have done in that conference, it's a whole day Sunday from morning till the evening, but on a Saturday afternoon, we've done a workshop. So there'll be 1 hour where Eduardo will come. Eduardo is really a guru on upper GI motility. There's certainly no one better than him. So Eduardo will talk us through the pH reflux studies, the impedance pattern, and then in the second hour of the workshop, he'll talk us through the manometry, so visual manometry. And then there'll be Maria Cossetti. She'll come and talk to you guys or us about anorectal manometry, followed by 1 hour of biofeedback, how to do it. So that's a 4 hours workshop. And the way we're trying to do it is I think there are only we couldn't do more than 40 people for the workshop. There'll be 10 computers and a group of 4. So you'll have a patient and his trace or her trace on the main screen. and then on your computers, and you'll pick up through the trace what that means. So you will be asked to generate a report, and then Eduardo will take you through why and what. So it's really, really good, I think, for trainees and the people who want to. Motility is very, very financially rewarding. So for units who really want to balance, like EUS is very expensive. EUS accessories are very expensive. Motility is a diagnostic work, and it pays off. Low risk, very safe, outpatient based. Patient come, they do it, they go.
Hello.
And you can
Hello.
off balance
Can you
the
hear
cost
us?
against your equipments for EUS and Endoscopy. So if people who have their own hospitals or they're establishing units, I think having a motility lab is very, very rewarding. And you can use that against your endoscopy. So it's something to think about. But yes, our conference is 5th and 6th, more than
Hello, can you hear us?
Mustafa, we are with you now in the room.
Okay.
You heard the story?
So it's a 14-year-old chronic pancreatitis case with history of recurrent abdominal pain for past 2 years. Patient is here for ERCP and PD stenting, and he's symptomatic currently for past maybe 2 weeks.
And you're able to share the images with them of the MRCP? Okay. So on the MRCP, the pancreatic duct is dilated diffusely with no definitive stones. And it's dilated and tortuous appearing, but does not appear to be devisum, looks like normal anatomy. So this is a 14-year-old, relatively small size, but not really small. But you just want to be careful and gentle with your scope maneuvers. So nothing forceful, just gently getting into the duodenum and reducing the scope to see if we can easily get to the papilla. And just taking breaks as you get down. Oftentimes, in these situations with the pancreatitis, and if it's not clear to me we didn't do any EUS here, but if it's not clear to me whether it's devisum or not, I may just look at both the major and the minor. They're very close to each other, for one thing.
Any tips for finding the minor?
So a couple of things. One is you can look for it on the way in. So I'll just pull back just for a second. So you can, as you go in the long position, typically as you stop in the bulb and you do small will to the right. Go through a deep cut there. And as you go in and you stay in the long position, you're just gently advancing the scope, small will to the right, and you're looking for the minor like that. So that prominent mound to the right is the minor. It'll always be medial and superior to the major, but the level at which you visualize it will vary. It can be as low as right next to the major to the right, or it can be extremely high. And the higher it is, the more technically challenged it may be. So there's our minor. Look, we're looking at it right now. Now, because it's a pressurized system, the minor is prominent. So the other approach would be, if in this approach you don't see it, we're just going to wait a second for cannulation to make sure the kid is more deeper anesthetized. You can also, if you get to the major and you didn't see the minor, you can also come back, go clockwise and back away with your big wheel looking for the minor that way. But now you have a very short position, so you can't cannulate from here usually, but you may be able to identify it. So those are your two routine approaches. So now I can see the papilla. The only thing I'm not sure about is if that divot is a fistula tract, which it almost looks like, because I can't tell if there's bile coming out of there or not. Or bile just like pooling in there. So I'm going to take the tome and I may just probe that area first. Interestingly, you do see stones from the PD occasionally fistulise out. It's not very common, but it does happen.
So, what were the features on the scan that
Did you see the
led you
pictures
to?
or no?
No, we haven't. But
Um,
was there anything in particular that made you decide that intervention may be the way forward?
Give me 1 second. हमारी fluoro image नहीं सही. Um, what I think the issue was recurrent pancreatitis with a dilated pancreatic duct. I do not believe in US has been performed to confirm if there are any stones or not. But I think it's in a young patient, recurrent acute pancreatitis who's symptomatic, a trial of ERCP to decompress the duct to see if they get better. I'm just trying to understand this papilla a bit, whether the orifice is there. The orifice looks like it's to the left down here, the papillary orifice. But then there's this here too. So just, and I don't know if this is like a variant of some sort, because now that almost looks like papillary orifice too. So I'm gonna probe this area with the tome first, just to see where this takes us, and we'll go from there. It's not a clear-cut, in quotes, normal appearing papilla to my evaluation. Wire tip. Try it. I'm not sure कहीं जाती है या नहीं. It may be a little diverticulum, that's all, but I honestly can't tell here. Anything or nothing? अगर pressure है तो ना करें. हाँ नहीं, leave it for a second. I think I'm going to go to what appears to be the natural orifice and then take it from there. So the other thing is, if you're depending on where you're trying to cannulate, if you're trying to cannulate, I think that's a little diverticulum, nothing major. So maybe because of the prominent papilla. If you're trying to get to the bile duct for any papilla, if this is your mound, you have to visualize the entire mound. And for bile duct, the trajectory of the bile duct is going to be down the middle of this mound. So right here, up the middle will be the bile duct, right? So yeah, our typical approach would be to get underneath it, come from below to aim for pancreas. That's for bile duct, typically. In pancreas, sometimes what you may want to do is just pull back a tiny bit. You have a bit of an understanding of where the bile duct is, and you may want to consider going slightly smaller to the left. Come in at it slightly higher, because that may take you to the pancreas. So that's what I'm going to do here. It's unpredictable though. Sometimes your wire may just go into the bile duct when you don't expect it to, and vice versa. So, but here, intentionally I'm staying a bit higher, and I'm going to go to see if I can get into the PD this way. And just for cannulation, I think the other thing that's important is, if you look at the fluoro, you can see the scope position there. If I wanted bile duct, I would try and get underneath it a bit more, so that and then my big wheel as I come up this way towards me takes me into the trajectory of the bile duct. So it's not unreasonable to use your fluoro to get a sense for how your cannulation is going to go. These are little things that can make a huge difference in cannulation, and with experience and some luck, you know you can get it right. So, but sometimes no matter what you do, you end up in the duct that you don't necessarily want to get into. Okay, so I'm going to just ask for the wire tip and gently probe this orifice to see where it takes me. So I feel like the wire there was a bit of a give, so wire please. Yep. Okay, slowly. Now pull me in. So I'm not necessarily going to, if the wire is engaged into something, I don't want the wire to just keep going randomly. My preference would be to get in with the tome and actually do a bit of an injection if I can. So pull back the wire, Okay, now we're going to inject a bit.
Ready?
Yeah.
Injecting.
Um, wait a second, stop. So contrast is coming back. Mag up, please.
Max zoom
Zoom kar de.
zoom कर दे.
Zoom. Okay. Inject again.
Ready?
Yeah.
Injecting.
Again, it's not clear to me if I have anything. So we're gonna ask. I'm gonna ask for the wire one more time. Wire.
Right.
And see if that there's a give anywhere. I also need to be thinking, if I am the PD, is this a Devison case? Pull me in slowly. Or is there obstructing stone? Because remember, MRCP may not show stones very well.
What's the thinking behind injecting?
back
Is
wire.
it to dilate the duct or
No, to
see
visualize. We're going in
visualize it,
blind,
okay.
right? The wire is hitting a wall. I think I'm cannulated into something, very superficially inject. So that whole concept that contrast is bad in chronic pancreatitis is not necessarily the case.
You need contrast.
Yes, contrast.
Okay, ready?
Yeah.
Injecting.
So I'm getting nothing. What's interesting is it's coming from that top orifice. You see that? So I think there is a fistula of some sort here. Because when we're injecting here, it came out from there. So now I feel a bit more confident probing this side too. Maybe that's why we're not necessarily filling it too much. So now I'm going to ask for the wire again. Wire.
What makes you choose the wire tip cannulation over just plain cannulation?
Because it's a small orifice, I think for here I would. Now though I'm feeling a bit more confident. Actually, contrast.
Ready?
Yeah.
Injecting.
This may be a. Like now we're going to see contrast come out the other way. You see that? Which makes me wonder if I should consider doing a pre-cut, because we may keep doing this circle of contrast, a loop. But we're going to try the wire from this side a bit more, I think, before we give up on this. So try wire. And see if we can spin it upwards. Agar angle badalta hai to. We're going to see if we can change the angle to get it to go. I wonder if we're hitting a stone, but I can't tell with certainty. Try wire. Nothing? Okay, so stop. So other considerations are look for bile duct, and there's this thing too, I don't know what that is. Look for bile duct and see if I can get into bile duct and work my way from there, but I may consider doing a pre-cut here. The other is to try the minor first and then come back to the major. So I'm going to try and come from underneath it a bit more. Wire. Stop. Contrast. Yeah. Pull wire. Pull back wire. And then bow up a bit.
Would you ever consider making a cut with a sphincterotome in this position?
Yeah, I was just thinking that I felt a give here, so inject it.
Ready? Injecting.
Try wire for a second. If I can get bile duct, I'd feel a bit better, but I could just cut here for bile duct too. I'd prefer to get bile duct without cutting if I can. We have multiple choices here, But I wonder if we're hitting a stone here. And I wonder if going through the minor may not be such a bad thing. Bow up a bit. So I'm trying to bow up more towards the bile duct. I just fell out, so I'm going to try that again. Bow up a bit. And see if I can get above the septum. But of course, if there's an obstructing stone, that may prevent this from being successful. Try wire. So it's the same sort of routine we're running into here. Pull back, bow up a bit more. Bow up, yes. Wire, pull back and bow up. The key is not to sort of rush it or get too aggressive. Just try and do gentle movements. The other consideration may be a cannula. Okay, there. Try wire. We keep feeling a give and then it just hits. So the other question is, could I actually safely cut her? Which I think I can. But once you cut, you're done in terms of your landmarks. That's the only downside of cutting. Bow up some more. So I'm going to keep trying to go more northwards towards the bile duct to see if I can get it. And if it just doesn't work out, I think I'll end up cutting here. Try wire. Yeah, everything is just leading to the same. But I may just cut this, bow up some more. Of course, you can overcompensate and then you're going too high. Try wire. Injectable. Yeah, gentle. Okay, so we have bile duct for sure. Keep injecting. So now you see that S, now we have to figure out how to get across it. So usually there'll be a gentle advancement of the wire to see if it can engage it. Yeah, try wire gently. Okay, good. And now I'm going to have him relax the bow a bit. Small will slightly to my left and pull back my scope to see if I can straighten it out a bit. To see if he can now push the wire through. And now it went right through. So that maneuver, when you have that S shape, small wheel to the left, back way with your big wheel, and just gently pull back the scope, oftentimes will straighten out the bile duct to allow you to get in. So now we have this relatively large mound which we're going to cut and then see if we can get PD from there. If that doesn't work, then we can look at the minor. So ready to cut? Okay, principles of sphincterotomy are basically you want to cut up the middle of the mound for the bile duct. So look at that mound, imagine where the center of the mound is, that's where we want to angle. Oftentimes if your tome starts cutting to that 1 o'clock position, the maneuver to do is slightly small wheel to the left, big wheel towards you, and that'll take you more to that 11 o'clock position, which is I just did. And then I'm going to ask for a bit of bow here, so a bit of bow. Okay, good. And then I'm going to cut. And we're, yes, ready? And we're doing a...
Mustafa, we're gonna, we'll stay with you for sphincterotomy and then we'll move to POM.
Of course, yeah.
Okay. And then you can go after PD after this.
Yes, exactly.
Okay.
Okay. That should be good for the bile duct. Just let me know whenever you move on and we'll keep trying on the PD.
Okay, so we can present that case and go there. We're still with you in for maybe a minute or so.
Sure, I'm just going to look at it because there's that gush now, so we're going to look to see if we can identify the PD orifice. So again, just taking my time to study it, not rushing this.
Okay.
Farouk, we're with you.
Okay. Thank you.
And yes, we see you and we see your endoscopic views as well.
Lovely. So this is a 50-year-old lady who had achalasia or swallowing difficult needle eye place for a few years. And then she had a balloon dilatation, which gave her about a week's result, and then it's all gone bit haywire.
You have seen foam before? Never?
So at this point, what we've done is, so she's really got a sigmoid esophagus. I'll quickly show you her esophagus. This is her esophagus there. And that's the GOJ,
Yeah, we see that.
which is at about 43. I'll just show you.
Okay.
So that's her. So GOJ, it's always difficult as you go in, so it's much better to assess it as you come back to have, we think, a GOJ is really at about there, 42, we think. So we've come back up, we're going for a posterior approach, and at about 34, here, we're going to start the tunnel with the. So we've done the submucosal injection, and she's got a lot of inflammation in the mucosa, as you can see. Probably these are the patients who may benefit from fluconazole. And so what we normally do, we've done the incision, and I normally trying to bring it, we'll do the injection here more before we go in.
So you see that white area, this white in there, those are the muscles, and you see a circular muscle there, and and what he's trying to do is like get into the space.
But injection, I don't want the.
You get into the
just give me the
submucosa,
injection.
right above the muscle.
Injection,
And,
yeah, go for
so
it.
he will inject there and see
Yeah,
it's going to turn blue.
Go injection. Yeah, lovely. Okay, needle back.
So how do you determine what is the posterior surface and anterior when you are in the patient, right?
So the way
could be
we assess
problematic.
for the posterior
So-
is we come back.
So
and
for
we look for
these
the.
poems, what we do is we keep the patient in the back. Wherever
I
water
think we need more
accumulates, that's the
injection here.
posterior.
We didn't quite get the lift we're looking
Easy.
for.
Under the gap.
You know? Like injection needle there.
So he's doing a posterior approach. There is another achalasia patient. I'll do that anterior approach so you can see both of us. These dilated esophagus, usually you need to do a posterior approach because it's hard, difficult to enter into the tunnel
Right.
in the anterior in dilated esophagus.
Needle.
No, it's just presumably maybe less risk of post-form reflux because you can try to avoid that.
Okay, needle action. Inject. Yeah, very nice. Keep going, keep going, keep going, keep going. Keep going, keep going.
What solution you are using? It's a methylene. It's a methylene blue in that, or
Indigo carmine. Is it
indigo
methylene blue?
carmine. And what is the solution?
Yeah. Go, yeah.
Starch.
Okay, needle back. And I'll have TT there. So I don't use methylene blue for all my submucosal lifts. We really do prefer indigo carmine.
Yeah, we don't have. You guys are rich in Dubai. We don't have indigo carmine.
Now even in UK we use indigo carmine.
Yeah, it's on short supply in US.
Oh, I see.
So we end up using a methylene blue. But methylene blue makes it really more blue. Indigo carmine is better because it gives you a nice tinge. It does
Needle
not
out,
make
please.
it too blue. And which knife are you using?
So TTJ,
Okay. So there are so many different types of knives. One thing you need to make sure know the length of the knife, and some knives you can use them to inject as well. There are other knives you cannot inject through those. So this
So needle out, please. So I tend to keep a needle, as you can see. यार इसको थोड़ा सा adjust करें. चलो.
So that's in that nice submucosa there on the, and you have to orient yourself. Which side is the mucosal side? Which side is the muscle side? Because here, eventually we're going to cut the muscle. So if you damage a muscle, it's fine, okay? But you don't want to damage the mucosal side. So staying towards the muscle side and oriented yourself, the knife is facing towards the muscle, not the mucosal side. No, this one, the muscle I see at the bottom, right? No, no, we're doing esophageal, not G point. It's a E point. Fine. Okay, I think you walked in late, so it's a. Yeah, yeah. No, no, he's starting from
working.
esophagus.
It's not नहीं कितने पे अभी?
I,
नहीं 60 पे तो बहुत है इसको चलना चाहिए. Yeah, it's now doing. So
Farooq,
what we
where was the GE junction?
So 42,
And where did you start the incision?
32.
32. You're doing a 10 centimeter almost.
Yeah.
Okay.
Okay, so one of the ways, because we know that this is a sigmoid esophagus. So one of the ways that I'm going to hopefully not lost my way in the tunnel is keeping really your muscle perpendicular. So you're walking on the road and at no level your road should be either tilted to the right or tilted to the left. And as long as you keep that in mind, you would hope that you'll carry on proceeding through this. This is one of the ways we would tend to keep an eye on, that we are not only we're heading towards the GOJ, sigmoid esophagus is always challenging to do. But this is one of the ways we really do that. You keep coming back, you keep looking at it, just assess your, and then we go back in. Keep injecting and making your way through. I'm just trying to clear the liquid from the esophagus because all of this will. We had, during intubation, this lady had a.
Even a randomized trial, non-inferiority trial, home worked better than the Heller model. That's a randomized trial. And for these patients with the sigmoid esophagus,
Okay, let's go back in. We've done enough
with the
cleaning.
diverticulum in there, sometimes home works really well. And the results 5 years success is close to 90%. So it works really well. That should be a thing. If the 30 is available and people are donating, they know what they are doing.
So we're back in the tunnel. We're keeping muscle at 45 degrees, as you see it. And let me just explain you here. So this is the muscle at the bottom. And look, one may just go straight this way, but actually it's not true. It's on the right hand. It's this way that I need to go. Keeping muscle at 45 degrees, yeah? Right, okay. Needle, please. Yes. So the knife that I'm using has got 3 abilities in it. It's cut, coag, and inject. It's a TT, triangular knife by Olympus, but it's TTJ. It's got a jet in it as well. So it saves us a time. We now also have Irby needles where the injection is also in the foot pedal. They call it Irby hybrid knives. You can take a pick what you use. I also use speedboat, which is a very different technology. It's a radio frequency. Okay. Yeah, needle out. Okay. Needle in. Inject. Yeah. Go. Yeah, inject.
So the knife you are using is not doesn't have an injection in there.
It has.
Okay.
It's a TTJ. Stop, needle back. Stop. Although I was expecting it to be a bit more injection than this, it's not really. So I might end up using. But one thing that I want trainees to look at the amount of even the fibrosis between the within the submucosal space itself. It's not so really easy. Okay.
Yes, please.
So we're just widening up here as we go through the tunnel. So at this point, I'm not quite advancing. What I'm doing here is widening. Okay, so we're still keeping muscle at this. As you can, we really do get a lot more clearer injection rhythm. So injection is not coming very nice. I think we have used this needle before, so we're just going to go and use our normal injection needle. We need to be a bit more quick, yes. Because we'll lose the space very quickly. So as you can see, the space is finishing here, so I do need to inject. There's a muscle fiber at the bottom, and just in the middle of my screen is where the mucosa is coming. We've tried injecting this, it's not quite lifting up nicely. So we'll just inject more. Oops, sorry, needle out, please.
Yes, please.
Okay, inject.
Yes, start inject. Continue inject, sir.
Yeah,
Continue inject.
keep going.
Continue inject. Continue inject. Continue inject.
Give me 10 minutes.
Yes. Again, continue inject, sir. Continue inject.
Okay, lovely. Thank you. Stop there. Yeah.
Yes, please.
Have a TT, please.
Yes. Line. Iftikhar bhai.
And now if you be able to see, we have a bit more space between the muscle and the submucosal. Needle back. Needle जब आप मुझे दें, तो needle back किया करें please. That's okay. Thank you. So short movement, short bursts. Okay, reassess, come back, and then reassess again. Okay, yeah, thank you. Keeping muscle at the bottom and just progressing your way through. And coming and now just widening it more, starting from, so that's the vessel. If the vessel is the size of the tip, you can just coagulate as you do. So when you open up the tunnel, you actually use the coag, not the cut mode. And if you do see a vessel, as I said, if you look at this vessel at 12 o'clock, it's cauterized now. If the size of the vessel is smaller than the tip of the needle, you could actually do it as you go along. If they're bigger, then yes, that will be the point when one may need to use the coag grasper. So there is. Okay, so muscle is still underneath. Okay, relaxing. Relaxing. So again, we're still running out of space. So I'll widen it a bit more. I'll go from the left to the right, and then we'll inject. Okay. So it's widened up a little for me. Yeah, so we're running out of space here. So needle back and inject. So we hope that it injects a bit more, but I think it's also down to the fibrosis that's, yeah, please. That this lady has. So we don't get the very decent lift with this. Yeah, keep going, keep going, keep going. Needle back, needle back. Okay, let's have a look again. No, we didn't get the lift that I wanted really, so I'll have the needle back. Again, as you guys can see, आपने scope ना पकड़ो, ठीक है? Yes, please. Okay, there is a bit of a bleeding, as you guys can see there. With the needle, let's just make the space there. So inject needle, when you are going to inject, look for the space where you can see some liquid, as you can see there. So that will be the place that we will inject to see. You see some bleeding there, that's okay, it's not obscuring your view, so you should be able to continue. At least you can lift it up, make use of that space.
So how are you getting close to the G junction, you think?
I'm at 38, Khalid bhai.
What is it?
38.
38.
Knee
Yeah,
left.
we're seeing those some of the vessels.
Yeah,
those,
exactly.
spindle
True,
vessels.
G, please. 10 mil. 10 mil, yeah. Exactly, yeah.
Close to the heart, yeah, you're getting here.
And it's getting a bit tighter too, yeah, you're right. चलें अब करें. Needle back. Let's assess and inject. So actually, rather than going this way, I think the tunnel needs to go this way, there, where the vessel is.
If you look here,
Because the muscle is perpendicular there, isn't it? दे दें मुझे कोएग ग्रास्पर दे दें, let's just sort it out, otherwise we'll start. कोएग ग्रास्पर दें.
Yes, please. Yes.
Close.
you using a coag grasper?
जी, I am.
So if the bleeding happens, if it's a little bit bigger vessel, yeah, you can coagulate that with a coag grasper. The rule usually is if the vessel is, you know, the shaft of the knife,
Okay,
the
open.
vessel is that size or smaller, you
घुमाएं
can
इसको.
use that to coag. If the vessel diameter is
Okay,
bigger
that's fine.
than that, then
Close.
get a special coag grasper to coagulate.
Okay,
And the way
needle back.
he's did it, he grabbed it
Turn
and he's
Turn
going
it
to
here.
pull it towards him, not just sit on it. Because that's going to otherwise get a lot of hot water.
What air is closed. CO2 बंद हो गया.
Can you just check them? Are they ready for us?
Okay, open.
Yes, please. Rotate करूँ.
हाँ.
Okay. Yes, sir. Okay.
और करें.
Yes.
Close.
Yes, sir. Close, sir.
Open.
Open.
Close.
Yes, close.
Okay. Yeah, I think we're. Yeah, still there.
Who are you texting? हाँ यार डायरेक्ट करें वो तो you have to go because whoever's coordinating I think now is saying.
But that we.
Okay. So
So we are back with you, Mustafa.
thank you. So basically we did the sphincterotomy, went to the minor, we couldn't get it. We came back and we went through the fistula and there was that rim of tissue in between from 4 o'clock towards the bile duct. And we put the wire up into the bile duct through the fistula and we just cut up. So this tissue that's hanging off basically got out of the way. And then we found this stenotic orifice. I don't know if you can see the fluoro.
What we don't, can we see the fluoro now, please? Fluoro dicado.
Fluoro, the kind.
Yeah.
So, okay, now you can see how it's really tight in the head. I don't know if there are stones or not. But I'm going to basically, actually there are, I think, on that. Do a pancreatic sphincterotomy, at a minimum balloon dilate, and put a stent in. We can always come back for the stones. So in terms of orientation, it kind of naturally finds its way, but you're supposed to cut more towards 1 o'clock, but bow up a bit. And so that takes us more towards 1. And I'm just going to like have more cutting wire on the outside and just cut inwards. Ready? So we're just going to cut here. And again, you don't want to go crazy on this stuff. You can always come back to do more. But ideally, I want to put in a 7 French stent today, so I do want it to be loose.
Want to cut more?
I think we're okay for today. I don't know what the preference would be, but I might just, it's really tight. I might see if I can balloon dilate.
Yeah, that's what was the question. Can we use a balloon and dilate it?
Yeah, balloon dilate and then put a stent in for today, and that might be it.
Yeah.
And we may, if it's really tight, I may have to go settle for a 5 French, but we can always bring the patient back.
I think distally looks quite dilated, and there's a stricture right close to the genu neck.
Yeah.
And so maybe just dilate that and
Exchange?
add up the pancreas. And
Yeah, exactly. Okay, so, and you can see the stone debris. Like, you expect that in a young kid with pancreatitis.
I think the way the wire is going and flipping that.
So,
There could be a
up kick it, do you do hurricanes or CREs?
Hurricane
Like I need a 6 maybe.
6 million.
टूट ना जाए बस stone से. क्या करूं? I need a 6. नया है कि used है? हाँ नया दे दो 6.
6 mm CRE.
I didn't, हाँ exactly. 6 to 8 वाला CRE दे दो. So I'm gonna go slightly bigger to see if it goes like a 6 to 8. If it just doesn't go, I guess we'll downsize.
Could be a stricture there also. Yeah, do you have a full PD gram on that, which you can see if there is any stricture in the distal body too, or no?
I don't have it. I mean, I would have had to, I couldn't get this tome in. I can downsize to a cannula or something
Okay.
and inject. But my thought was, based on the MR images, I don't know how old they are, the ones I saw, that the duct doesn't look too bad towards the tail. And you
Okay.
I think that loop is just in a very dilated duct in the tail.
Yeah, that's what you're saying, but Shahzad is very convinced there is a stricture right over the spine, like...
I mean, it could be, to see if we want to stent longer. I can, once we dilate, I can go back with a device to see if I can inject towards the tail.
Yeah, I think maybe just to make sure that there's there are not multiple strictures.
Yeah,
or something.
no problem. Anyway, whenever you need to switch, feel free. I just wanted to show you the access and the
Contrast.
plane is fine.
Yeah, you can put it if there is a यहाँ पे अगर वो हो pencil loop हो, you're having a really hard time getting through that, I can understand that. But the short stent, the problem with that is
I think हाँ
if it
चला गया.
ends up here or ends up here, every
काफी
time
लंबा
you're
गया.
get the paralysis
ये
of the
5 है.
small intestine, the upper end, inner
so
end is going to keep hitting the
the
duct there.
the centimeter
And it's
is
gonna
it's a 5 centimeter long, right?
Area of the pancreas is most vulnerable, and that's a watershed area. And if you look
Ready?
at all
Okay.
the necrosis and stricture
Gently
and all
start.
the
Yep.
indications, the stricture is kind
So
of
we
in
have
that
a
area,
5 centimeter
and
long
necrosis
balloon because it's a
also kind of
CRE,
starts in that area.
and we're just going to gently balloon up. Go ahead.
So
Balloon
I
up.
think main goal is the stent should be beyond this,
Okay.
or
Keep balloon up. Okay.
okay, it should not be ending somewhere.
1.5.
Okay, good.
Because that's the one which causes.
That's your stricture right there. Is it tight?
Yes, which size? Six,
Six, 6 to 8. Yeah.
yeah.
What's and how much is the pressure at?
3. Small.
So 3. So that's 6 millimeters.
Yeah.
So we don't have to go up more. I think it's a really high grade stricture though, you can see that.
Yeah, we can. Yep.
Okay, I honestly don't necessarily think we need to inject the tail, but if you guys really want me to, I will.
No, I think we're fine. It was just, I see that the wire is now looping back and it's pretty
Yeah.
open that area.
Yeah, I just want to balloon dilate this a bit more maybe. I usually don't pressurize the PD too much, but this is a pretty tight stricture.
Now, if you look at the
And-
it's looping and then like that. This is just,
Balloon up just a bit more. थोड़ा सा और कर दो. हाँ, वो फट ना जाए बस ये.
Shazad is satisfied now.
Oh, okay, you talked him into it? Okay. And then balloon down. We're just going to put the balloon down. So I guess the debate in my mind now is 7 versus 5 French. But I'm tempted to try a 7. If it doesn't go, then do a 5.
I think I would, yeah, I agree with that.
Balloon
Let's
down,
try Simon.
balloon down.
I think it's dilating, so you
Yeah.
might get through that.
Yeah. And you don't want to spend too much time and do too much. Just get a stent and get out and you can come back. The idea is not to over traumatize these fresh cuts. Ready? Whenever you're ready. Yep, yep. So Wasim's telling me to wait because I don't want to start pulling my balloon without coordinating with him or we could lose the wire. So we're exchanging. So I tend to, once I have the wire and if it's locking reasonably, I tend to stop doing fluoro and just look at my wire pattern so that we minimize fluoro exposure. Already we're magged up, but you don't want to compromise on fluoro for the outcome of the case either. So injection is okay, X-ray is okay because ultimately in trying to prevent complications and radiation exposure, if you don't get the job done, then what's the whole point? So you have to find that balance. So 7, 8, hey, do you have a 7, 8 or something? 7, 9? You could try a 7, 9, I think.
Yeah, 7, 7, 7, 9.
7, 9 might be my preferred choice.
7,
here.
9, please.
7, 9. Single picture.
He's soft enough. He's got a hard to me. See. ये ब्रांड क्या है?
ब्रांड देखिएगा किस कंपनी का स्टैंड है
कंपनी कौन सी? इंडियन.
स्ट्रेट करो ना एंग्री स्ट्रेट प्लीज स्ट्रेट प्लीज बस
Why are they muted? मुझे उनकी आवाज नहीं आ रही. I wanted to hear what he's saying. Oh, his mic is off.
उनको बोले इनका माइक बंद है.
Dr. Khalid, if you can turn on your mic, I'd love to hear what you're saying.
Okay. I think I was not just speaking in my.
Oh, sorry
So
about
sorry.
that. Okay. No,
So
no.
for the sphincteroplasty, stricturoplasty, just gotta make sure that if your balloon is still through the orifice, you gotta follow the same principle. Okay. If it is inside the duct, however, then the whole goal
Advance
is
wire,
to
advance wire.
open up
Push
the
wire.
stricture. ठीक है.
Okay.
थोड़ी देर लगे, आज 30 seconds लगे, या 3 minutes लगे. You take your time on that. Make sense? Disappearance of the waste of that. And it may take, sometimes it takes really long time for it to disappear.
It's a marker.
Yes, yes.
ठीक है बस, ठीक है.
I think you can get an idea with the ear as well sometimes. Like even though you,
Give me 1 second.
not ear, I mean the fluid itself. And you get an idea on that.
Ready.
I know you are not using contrast, but you can get an idea. So in that case, I would just try to figure out the balloon is dilated completely or not. If not, at least 2-3 minutes. Okay. Yeah.
So I got a 9 centimeter and I intentionally left it out of it because I could see the tip was getting to the tip
So-
of the loop.
So it's a 9 French?
So 7 French,
7 French,
9.
9 centimeter. Okay.
Yeah, I mean, I'm just deciding whether I should pull it back a bit more or if it's okay.
No, I think looks pretty good.
Okay.
Yeah. Well done.
Thank you, all done here.
Thank you.
Thank you.
We can go back to Farouk now if he's ready.
Oh, thank you, Sabi. I'll talk.
Are we live again? No, okay. Need a live, please. So this is what we're going to do now, sadly, whether we like it or not. The whole, are we live now? Can you guys, so are we back live?
Yeah, we are.
Achha, Khalid bhai, I just wanted to show you if people can look at my left hand, which is this. So look how far I have to come out on the sigmoid. So for me to be able to, in the submucosal space, and keeping the muscle perpendicular, this is how far I've got to come in. Needle out, please. And even then I'm struggling to reach there, despite the fact that I'm really doing it in the, because as soon as, so if I put in the neutral position,
Yeah.
which most of the people would prefer, can I just convince you all that the muscle has gone completely on my left. So my direction would be very different. I'll be walking towards the liver rather than walking towards the GOJ, if that makes sense.
Yes.
So, so this trick, that keeping the muscle perpendicular at all times, this is what really has helped us so far. And as Khalid bhai has said, as we're reaching the GOJ, not only the space is getting less, it's becoming very blood here. Injection
Can you hear us?
needle back, inject करें यहाँ पे.
So where are you right now? Oh, actually, Shazad, we are with you.
Yes.
Yeah,
Okay.
so sir, this is a
Tell-
case of 21-year-old
Yeah,
patient
yeah.
with history
Yeah.
of recurrent acute pancreatitis
थोड़ा सा
and
size बड़ा
multiple
कर दें.
ERCPs.
Shazad, can you hear us?
Yes, we can hear you very well. Can you
Okay.
hear us?
Yes, we can. We are
Okay.
with you.
Okay, excellent. So basically, it's a young girl who has had recurrent pancreatitis and has had ERCPs and PD stents placed in. But her main complaint has been pain, and therefore she's been referred for a celiac block. So the plan of us is to go in, inject some bupivacaine and some steroids, some Kenacort. So I've just put the scope at the GOJ, and we just assess the aorta coming up, and that's the crux of the diaphragm. And the first vessel that's coming off it, we'll put some Doppler there just to visualize it. Just put some Doppler, please. Yeah, so the first vessel that's coming up is the celiac axis, and just above it is the area of interest where we would like to put the block. Now, some people advocate that you look for the ganglia and try to target those. In practice, I don't usually find them, and I'm not sure about the group, but whenever I've tried to actually target the ganglia, I've not found any difference. I'm not sure what the group thinks about that. But then you can also do a broad plexus block, which essentially is just above the SMA. In this particular case, the plan is to go ahead and do a celiac axis block. Now, in our practice, we tend to do celiac axis neurolysis, most for cancers. Blocks is not something that we do quite frequently. And one of the reasons is that obviously the effect of it is quite temporary and usually lasts less than 6 months. But in this particular case, an intervention has been done. But while it's taking effect and the patient is still in pain, the idea was to see if we can reduce the inflammation and the pain. Okay, so this is my area of interest, just above the celiac axis. We're just seeing if we can find any, ganglia there. So can we put the Doppler on again? Excellent. So this is going to be the area that will be going in. Okay, so if I can have the 19 gauge needle, if you can switch the Doppler off, please. I usually lock the wheels just to stabilize my position. Keep it at an appropriate place. So the idea is that we'll first gain access, yes, with the 19 gauge needle. Once we're in the space, we are going to inject 3 mils of saline just to make sure that we're in the right place. Prior to that, we will do some suction just to ensure that the needle is not in the blood vessel. After injecting the 3 mils of saline, we're going to inject 8 mils of 0.25% of bupivacaine, followed by 2 mils of Kenacort. We then tend to inject 3 mils more of saline, especially if you're injecting alcohol in a neurolysis, because you don't want the alcohol to be injected in the gastric wall.
Shazad,
Yeah.
Assalamu alaikum. This is Saad. Shazad, ये बताएं, in your experience, what percentage of your patients actually benefit from this block? I'm sorry, you may have said that before, but I missed it.
So, as I said, in majority of the cases, I tend to do it in malignant patients. So I would say 50%. They have benefit. They do have some immediate benefit because of the bupivacaine. And then they are probably still on some sort of pain relief from the pain control team, but the amount of pain control that they need is usually less.
Okay. So there's a difference between block and obviously neurolysis.
Yeah.
So neurolysis, you're using alcohol, you're trying to completely burn the fibers, whereas here you're just actually making them numb for some time. And whether you do neurolysis or you do block,
both, I think it's very important to counsel the patient properly because a lot of patients will not benefit, and it's really disappointing. A, they continue to have pain. B, they've gone through a procedure and it has not been beneficial.
Yeah.
So it's very important to actually counsel your patients beforehand. They are very frustrated patients. They've been having pain for a long time. Pancreatitis, chronic pancreatitis is a horrible disease to have, and unfortunately, a lot of them are not even surgical candidates. So, counseling, I think, is very, very important.
Yeah, so the expectations should be managed as well, yeah?
Absolutely.
Yeah. So we've got the needle coming in, and we're just trying to aim the area. Just one last time, I'll put the Doppler on. Just can you put the Doppler on just to make sure that's too much gain of the Doppler. Can we reduce the power of the Doppler so that, yeah, you're reducing the size of it, but the gain of the Doppler, I'm not sure with this equipment. Yeah, excellent. I think that's maybe giving us a better view. Okay, just take the Doppler off, please. Excellent. So we know that the vessel is there. That's the celiac axis. So we'll just access the area. No. Just wait first. So we've just made the tip a bit sharp, but that's just enough.
Sir, I've got a question. I've done pancreatic rheolysis as well as
now
block.
you can take it off.
So I've been using
we are in the space.
steroid in case of. So I have a question regarding the preference of steroid. So in case of malignancy, I've been using alcohol, and in case of chronic pancreatitis,
3 mils of saline आपने इंजेक्ट करना है, ठीक है? जब मैं आपसे कहूँ, ठीक है? आपने पहले इंजेक्ट करने से पहले सक्शन लगाना है, सक्शन करना है, ठीक है? हाँ. So we need to apply some suction first, just to make sure that we don't have any blood coming up. That's fine. Now we can inject some 3 mils of saline, and if you can see that area is enlarging, yeah, excellent. And at this point, we're going to get the bupivacaine now, yeah. So that's 0.25%. It usually comes in 5%, so you mix it up half and half. And we're going to inject 8 mils again, suction, that's great, okay. And if we inject, yeah.
Is chronic pancreatitis start?
Yeah, keep on going.
Keep going, sir.
Keep on going. When it's 8 mils, let me know.
In case of chronic pancreatitis, if the patient is not responding to steroid, so can we use alcohol?
Excellent. That's great. So we've got the 8 mils of bupivacaine. We're going to now inject the 2 mils of Kenacort. Yeah. Excellent. Yeah.
Case reports or studies
So that
of
is
using
being
alcohol.
injected. Sorry, आपका नाम मेरे जान से निकल Adil. So Adil is very skilled in doing it. He's actually on autopilot here. So we'll just do saline now. So I think in this, and like in gastric gluing, you need to know your team very well, and you all should be on the same page. Excellent. So if you inject, yeah. Yeah, excellent.
Done.
Excellent, that's fine. So we have done all of the injections. So we've injected saline, followed by bupivacaine, then Kenacort, and then saline. So we're going to remove the needle. So usually if you have injected alcohol, you see a snowstorm appearance. In bupivacaine.
Shazad, one question for you.
Yeah.
Needle, you have any preference? Like, do you go with 19 always, or do you use 22 as well?
So
because with 19 it's very easy to inject, whereas in 22 you need to put a little bit of pressure. So your views?
So in abroad, there are certain needles that are specifically made for doing blocks, which have got lateral drainage as well. Here, if it's just block that I'm doing, then 19 gauge, because as you said rightly, it's easy to push in. However, because of the costs, etc., in our country, we have to use just one needle. So I've done a lot. Most of my blocks have been with a 22 gauge, F&B needle. So I've gone in, done the block, do the biopsy, and come out. So you do multiple things at the same time.
Okay. So, and do you just go in and inject at the celiac axis, or do you go to both sides, or do you, if you can see the ganglions, do you try and inject in the ganglions? Any preference that way, or you just do what most people do, just going on one side? And
in majority of my cases that I've done, I've gone in the center and just injected it. I try to find the ganglion, and if I do try to inject in it, but in reality, it's not something that happens every day. I don't tend to go on either side. That's another technique that people tend to use, but I tend to go single off in the center, Usually I'm not able to find the ganglion, I'll just inject and come out.
So the evidence isn't in support of any technique. People have used both sides, going, rotating, going the other side, injecting there, and then on the similarly ganglions have been injected. But conclusive evidence in support of one technique or the other isn't there. So most people, as far as I know, if I would agree, most people would just go find the celiac, take off, inject there, and that's it.
Thank you. Thank you very much. Sorry यार ये उतार देना आपको। अजीब आप लोग कितने ब्लॉक्स वर्सेस न्यूरोलाइसिस करते हैं क्योंकि हम लोग तो यूजुअली न्यूरोलाइसिस ही करते हैं ब्लॉक तो हमारा तक कितना
हमारा ब्लॉक का रेशो हमारा
ज़्यादा कम है अच्छा वही ना क्योंकि जब जाए गए हैं अंदर तो एक ही दफ़ा उड़ा दो
ब्लॉक हमारा भी कम
ये अब पता नहीं चल देख ले फिर ये पीछे वो को तो नहीं है
Close कर दो. Thank you. Just touching it is fine. We don't even have to do. Yeah. नहीं आ रहा पहले भी है हाँ दे दो open rotate okay that's fine that should be okay close
Farooq, we are back with you.
thank you sure. So we write at the GOJ now and it's the right time so what are the markers that tells us we're at the GOJ. So if I can convince audience there are these, can you see at 6 o'clock there's a spindle vessel there, yeah? So that's one. Then the space is really becoming narrow here. So this is your tunnel as you can see. You walk on the tunnel, you walk on the tunnel, you walk on the tunnel. The tunnel is really swinging away like as you'd expect in sigmoid difficult esophagus.
Farooq, can you just point out, a little bit about the tunnel, as in where is the esophageal lumen and where is the...
So right at the bottom of my screen at 6 o'clock, so from 4 to about 7 o'clock is the muscle, yeah? So we've kept the muscle at perpendicular and at the top of me is the mucosa. And as everyone would likely to be appreciate that as I move, esophagus really moves. So I have to go to the left, then come to the right to be able to stay. So this is a relatively complex, challenging, and even the submucosal fibrosis is such that it's really even holding my scope. I'm having to, as you can all feel on your screen, it's really holding my scope there too.
Yes, we can see that.
Yeah. So now we're so one of the ways that we will look for whether we A, the direction is right, and B, we are not far from GOJ is come out. So that's where the incision was. So it's on my 6 o'clock, 6 o'clock, we're moving 6 o'clock. You can everyone see that bulge at 6
Yes,
o'clock?
we can see.
Yeah, so we're in the esophagus, we're still in the esophagus. And the bulge is now moved.
Very clean tunnel, Farooq.
It's now moved to about 9 o'clock, but we are still heading towards the GOJ. So the tunnel is now at 11 o'clock. People can appreciate that. And that's the GOJ right in front of me. Yeah. So we've not quite reached the GOJ there. So we're in the stomach. So coming back, so that's the GOJ as you can see.
So how far into the stomach do you normally?
2 centimeters, Advai. I really wouldn't go. Endoflip will always educate us better. But
2 centimeters.
2 centimeters. So
Below
now
below the junction, right?
bulge is still going on, going on, going on. Now the bulge is at 6 o'clock. And this is where the GOJ. So I'm just about 2 centimeters away getting to the GOJ. Yeah, so we'll come back at the top. We'll go back in again in this space. We'll just clear all the liquid. Whilst we're out it, we'll make most of it. And the patient's fine. Tummy is quite soft. Certainly no third space emphysema at this
Khalid, sorry, Farooq, would it be possible for you to show us the esophageal lumen?
Gigi, I will. You mean before the tunnel?
I mean, with the, just looking at the
yes. Okay, so
at the junction from.
Let me come right from the top. So
Yeah.
we're now at 20. Yeah, that's the start of our esophagus. You would like to go forward, but it says no. I'm actually. So if you can, guys, see my left hand with the scope, it's like in D1. From look at this.
Yeah.
For me to do this is called sigmoid esophagus.
Yeah.
Yeah. So we started the tunnel at around 32, so we should be able to get the incision here somewhere. That's the incision for the tunnel at 6 o'clock. And then as you come all the way to the right, it had decided to move to the left. So look at my left hand now, it's gone below my waist to be able to move. So look at the amount of movement. And now compare this. So this is the lumen of the esophagus, which is about 15 to 18 millimeter. Now compared to that 2 to 3 millimeter space. So this movement is not there, right? So it's utterly important, really, really, to keep going in that limited space. And the only guiding star is the muscle. So keep the muscle perpendicular, you should be okay. Imagine if you don't really have a guiding star, you can go anywhere in this. Anywhere. It really is difficult case. But so far, so
We
good.
selected a good case for you, Farooq.
Thank you so much, Saad bhai.
Let this ready, I'm told, with the MP. So if you are going to.
Gigi, let's just keep moving between the stations. That's
Okay.
fine.
When you
If
think
I
the
reach, if
the
I
muscles,
reach,
then you just call us back and
yeah. When I reach a milestone, I'll
yeah.
call everyone
Thank
back.
you. Can we move to the, I think, endo fluoro 2, please?
इसकी पहले कौन प्रेजेंट करेगा केस को?
Khalid?
केस को कौन प्रेजेंट कर? जी,
We haven't, we can hear you, but we can't see you, so just give us a second. Now we can. I think we are probably in your room. Khalid?
not yet. I don't think so. But you can hear me, right?
Yes, we can hear you.
Has the case been presented to you yet or no?
No.
Okay, Novo, can you present the case? Just give them
Asim
a
is here. Asim is going to present.
Asim, okay.
He's a 34-year-old guy with a history of
34 or 42?
obstructive jaundice almost 2 years back. Has a history of multiple ERCPs and stenting. Recent ERCP was performed almost 2 months back with placement of 10-7 stent.
Okay.
We found bulky ampulla. Biopsies were taken twice that showed benign glandular epithelium, no evidence of dysplasia. The imaging is showing no sign
Unlock
of
करो इसको.
invasiveness, and CA19-9 is also normal.
Unlock कर दो. Okay, ठीक है. क्या नाम है इसका? क्या नाम? Asim? Asim, can you speak in the mic?
Yes, sir. I have presented the case.
Okay. So I guess I'm trying to understand because I don't think we have adenomatous changes.
No, the Mustafa, what I want to show is I just took a stent out, and it's a very bulky lesion. None of the biopsies have shown it to be adenoma. But if you, I want to just show the lesion. And what I decided is after taking the stent out, do a EUS on this because it's a quite bulky lesion. And so it's a, it could be adenoma, it could be more than that. And surface looks like it possibly is a adenoma actually. And adenoma or at least a mass there, something. Good size lesion. Look at that. Endoscopically.
Yeah.
Okay. So that's where it, and it extends downwards quite a bit. So let me show it to you from the top a little bit with the endo image if you can see that, and then I'll put a EUS on that.
Mind
So
you, this patient was symptomatic, so you presented with obstructive jaundice
yeah,
and
he
had
did,
a stent
yeah.
placed,
Okay.
and this is, we were referred this patient not very long ago from another center where ERCPs had been done before.
Okay. Can I have a fluid, water? So
We started about 2 years ago.
So is there a, one of the questions asked was, is there a size cutoff for you, assuming this is not invading into the duct or the duodenal wall? Would you have a size cutoff, Dr. Khalid?
what do you think? You don't want to answer?
I think
There is no size cutoff basically, and what I would like, the only main thing is gonna be if there is a really invasion of the ducts. Is it an invasion beyond the muscularis propria? And is it invading into the pancreatic duct? Majority of these mostly they invade into the bile duct basically, and here the image is I think it's acting up again this Fuji or Daldo fluid. Okay, and you can see the lesion there clearly. I just need
Yes,
to
we can see that.
figure out where it is going. Is it extending down into the ducts or not? And it looks a good size or Daldo thoda sa. Okay. What I'm doing
here you can see the MP is to the right of the lesion, right?
G.
The muscularis propria is to the right of the lesion, so
Yes.
it looks pretty spared here.
I will show you in just a second.
Thank you.
Okay. So I'm just trying to put some fluid in there, but it just keeps running away from us, which is okay. So here on the right side, as Mustafa pointed out, okay, so muscularis propria is on the right side. You see one of the ducts, and I think that's a pancreatic duct. Bile duct had a stent in there. You can see a little bit debris in the bile duct on the top. Here, PD is pretty okay. Saad bhai, the images has gone back to the day one on EUS on Fuji.
Is there an auto button on it? If you can press that auto button.
Can you, इनमें से कौन सा? ये वाला? Okay. Basics. Yeah, see, it was, now it's a little better there. I think it was Wasim.
Or Shehzad, because he.
I mean, we like to make things difficult for you, Khalid.
I see that.
Yeah, because there's no point, straightforward things are.
Does anybody see something there which might concern you?
Is there a lymph node or as
Yeah,
well?
it's a very, it's not a nice looking lymph node.
I think so. A couple of other features just from the history, the duration of this problem for 2 years, and then initial presentation with jaundice is generally a
Bad
bit of
sign, yeah.
It's a concerning feature.
But Mustafa, this looks more like a mass to me. Look at that.
But we
It's
could definitely,
you can appreciate that, right? It's a it's a mass. There's a here the muscularis propria looks good because it's hanging down
This is
there.
good.
This looks good, and muscle comes straight close to it. It's here. It's mingling with the muscle right there, and it's.
And the other
then
thing
it
is,
comes.
I think Shahzad pointed he thought there was something maybe in the distal PD.
Yeah,
Like-
I think if you go to the PD, I'll show it to you right here. I don't know if it's. This is the PD, by the way. It's dilated.
Yeah.
And
Yes. And just proximally more towards the bile duct. What do you think there?
so bile duct is right here on
Yeah.
the top. You
Yeah.
see some tissue fibers in there. Complete. There is some debris too. When I took the stent out, there was a debris on
Yes,
that.
yeah.
So here, this whole area of the bile duct right there.
Khalid, the fact that the patient has had stents for a long time now, how much of the changes due to stent would actually affect the way this
Needle.
whole area looks?
Yeah.
Distal
So,
part.
yes,
The
so
distal part of CBD.
yeah, the stent can cause some reactive, reactive changes there. But Saadbhai, if you look at it, this one, there is a complete loss of muscularis propria when I get to the bile duct area, right there. So it could be some. Actually, there is some muscularis propria we can see. Right there, we do see some of it, but there is a loss of differentiation in this area right there. This is my feeling is I think we should do a FNA of this. It looks like a mass there. It's behaving like that.
So we agree. The other thing that I wanted to know was if you're not getting biopsy results with your regular biopsy forceps, do you do a snare biopsy here if FNA or FNB was not available?
If I wouldn't do a snare biopsy, that's going to really put this patient at risk of bleeding, quite significant. If I have to do, I would either do a regular biopsy, do a FNA, and if it is resectable, go with that. Right now, I am struggling with the fact that there is a lymph node. It's a very, actually two lymph nodes. One is here. You can see that at the bottom here, right there. You see that? That's an ugly looking lymph node. And then there is another one right there as well. A benign disease probably wouldn't causing me lymphadenopathy like that. Needle de do. No. So I think we're going to do the FNA and see how it looks like. What is the consensus? Do you think it's resectable? If FNA is benign, or what do you guys think? It's a very bulky lesion, by the way.
I think the question is, do you think there is any window for the Lymph nodes or not really?
I think I'll have to go through the pancreas, but
Yeah.
I can try that.
Because if you have a positive node, then
Yeah,
obviously
I think
endoscopic therapy is
here,
not.
I think I can get there, but there's gonna be some pancreatic tissue right here. I can. That was one first lymph node, and then there is a second lymph node.
This guy.
Yeah, this
if
one
there
is
is
a
a way to get this.
that's gonna be tough to get to because it's in
Exactly.
from D3 or downwards, I should say.
Yeah.
Distal D2.
And
Let
from
me just
here,
do the
PD's in the
FNA
way.
of this mass and see what that
Yeah.
shows.
Yep.
हाँ जी, निकालो। नहीं, थोड़ा सा निकालो। बस बस। But this is like not a simple ampullary lesion.
The Dr. Shahzad wants you to do elastography on this.
Oh, I think we did not buy on this machine elastography.
I think it malfunctioned this morning, but
Oh yeah, yeah, it wasn't working at all. I can in just a second. Give me a second. इसको पकड़ लो स्कोप को यहाँ. नहीं, relax, relax. यहाँ पे. ठीक है, निकाल लो उसको slowly. I feel like I'm getting a tissue there, Saad Bhai Mustafa. So that concerns me.
I think we're just having that's very nicely demonstrated, by the way, you're sampling.
So it's, Gee.
How are you changing the fanning that you're doing?
This is like right now big wheel is towards me right here. I pull the needle back. I don't take the needle out of the lesion. You see that it's right at the edge but not out of the lesion. Moving a big wheel a little bit away from me and then go back in. You can go in one area twice, but don't try to go more than twice with the core needle. Now moving the big wheel further away from me and going that area in that area. And if this doesn't work, then what I can do is like right here, bring the needle back, release the elevator if I have used the elevator, or use the elevator if I have not used it.
So the point is that you can use the elevator and the big wheel to actually do the fanning technique.
Correct, but your preference, you have to go with the preference. What is the preference? Yeah. I would avoid elevator if possible because that would bend the needle. That would be my last resort to do a fanning technique. My biggest friend would be just the wheels itself, or moving the scope in or pulling the scope back. These are the two number ones.
So the other thing is that he's talking about FNB here, okay, with 2 times. When you're doing FNA, which is done now less and less, you go into the same area 4 or 5 times and then you change and then go into the next area 4 or 5 times, you go change next area. So you end up making at least 16 not passes but actual hits. Yeah. Whereas with FNB, you go into one area, you do one pass.
Two lymph nodes.
When you start doing it, you can feel
and then there is a bigger one
the slight resistance as you're doing it. So 2 times at one area, then change 2 times.
Or
change 2
iska
times,
stent dobara dal
2 times, and that's all you need most of the time. If that doesn't work, in our practice, we use suction as a second.
So I'm gonna, I will make one more pass of this and then I'll go down further to see if I can get access to the node. If I could, I will do that.
Okay.
And I'm leaning more and more towards probably should not do it. This is involving MP right here. It's like mingling with the muscularis propria and there are lymph nodes around that. I don't know what your thoughts are. Here, I think it's not gonna be a complete
Yeah,
ampullectomy.
it looks like it's invading through.
It's invading
Yeah.
right there. You can
and
see
then
that.
you can also, if you don't have EUS, but the lesion is bulky and you're worried, obviously you can take biopsies at the surface, but you can also take intraductal biopsies because this patient presumably has a biliary stricture.
Oh yeah. It
So
presented
you
with
can
jaundice.
Yeah,
so
so
yeah.
in these situations, if EUS is not easily available, ampullary biopsies as well as intraductal brushings and biopsies, if feasible.
Look at that.
So,
This lymph node. Yeah.
The
Looks
point here
ugly.
is that I think it's good to see procedures, but I think it's equally important to know when you can't do them or you shouldn't do them. So, can we, Khalid, while we are waiting for this, can we go to Farooq?
Yeah, please do. ये इसकी picture ले लो.
Yeah. Are we live now?
ये देख रहे हो? This is a malignant
Okay,
lymph node.
lovely.
No, not average. तो इसमें चूंकि bulky थी, it's a
Are we
old
live now?
patient presented
Okay.
with jaundice.
Farooq, we are with you again.
Okay, so esophagus, lumen. So we think we've gone past GOJ. I'll show you inner in a minute. So that's the spine bulge, yeah. And once we reach forward, this was our entrance. Everyone can see that 7 o'clock, right? So that's we go through. Now the bulge is on my left. Let me keep it underneath so you guys can appreciate the bulge. Submucosal bulge is now at 7 o'clock. We're still going through the bulge at 7 o'clock. This is a GOJ. Yeah. And in a minute you'll see. Can you still see that bulge at 8 o'clock? And there. So what we normally do, we
Yes,
then,
Farooq, we can see.
so, the difficulty with the cap on, I'll just see if I can show you it's always on the lesser curve. That you should really confirm. So along the lesser curve, so that's a greater curve. On the left hand side is the bulge there. I don't know if I can show you with something there. So that's the greater curve you're looking at, the large part of the screen. If I go slightly left, now the bulge is there right at the top below if you can see that bulge. So we have gone and now I'll show you inside the tunnel. One of the other ways you confirm this is you suck the stomach air out, collapse it potentially as it were, and you start pulling it back. And you're looking for, so this is the mucosa where there is no submucosal injection. Yeah? And as we come back up, you should be able to see some blue. Can you see now on my left hand side? That's the blue marking. That's the red. That's where we've come through now. And we've come through, and that's the GOJ. Yeah? Let's go inside the tunnel and have a look whether we can convince ourselves. And if you're not convinced, honestly, there's there's no harm. You could continue. Let me just find the space again.
So when you're entering the tunnel, what maneuvers do you use?
So always bring the tunnel at 12 o'clock.
Yeah.
Once in the tunnel, then rotate it back.
Okay.
Always. It's just so easy. It's a natural. So this is, we are at muscle at the bottom. We are at about 30, 34. That's where we
Muscle
started.
very nicely there.
Yeah. So this is the widest tunnel I did, but can I convince you all? Look at how the muscles are still grabbing onto my scope. As soon as they see something, and that's exactly what they do to the food. As soon as they see it, they grab it. And patient can't eat, they have pain. So can you see that I'm having to push the scope? I don't know whether you can get
Yes,
that.
we can see it. We can see it. Normally, once you've done this, scope goes very easily. In this case, you can see that there is that little resistance.
Why is इसकी ज़ुबान तो नहीं? That's not her tongue.
So, as you're having that resistance and advancing the scope, are you tearing some of those muscle fibers?
No, not that lucky.
No?
Not that lucky, no. So that's where you'd expect to see the GOJ. Gosh, this is really hard. So this is, we are in the tunnel, guys, yeah. Yeah, CO2 is on. Let me just put some water in, let's make it a little bit better. So that's the GOJ potentially from the inside. We're right at the GOJ and the tunnel has gone. For us to do the myotomy, we have to prove that we have gone beyond this place, which I will show you in a minute. At this point, the muscle is really, really in a spasm, and it's really not letting us go. Can you see that holding of the scope there by the muscle? And this lady has a dilatation as well, I'm afraid. Yeah, so can you see the tunnel going all the way beyond the GOJ? Oh wow, this is difficult. That's challenging. So we're ready to start the myotomy so that's the GOJ there. The one that's just holding the scope is the GOJ. That's not letting it through. And once the spasm is a bit more easy, we should be able to go past. Yeah?
Farooq,
G.
What's the scope? How much scope is in? What centimeters are you?
So we are, but that's not the truth. So this is right at 40.
You're at 40, right?
Yeah, that's where we thought the GOJ was on externally as well. So if it's not really going to do it, I'm doing, so what we normally do, if it does happen, we'll do a myotomy here first to give us some space, if that makes sense. And then it will open up to go a bit further, yeah? Okay, so I'll start a bit of a myotomy from here. So at this point, as you can see, the muscle is in full spasm. It's just holding my scope and not letting it go. We don't like to really push harder and harder because we know that this will. I know. So the question is, why are we not starting the myotomy from the top, all the way down there? So this is. Yeah. So that's the stomach there, guys. Okay. So myotomy, we will. So that was the GOJ where we've gone through it, and that's the gastric part of it.
Okay.
So our myotomy should really go beyond GOJ, about 2 centimeters should really just be fine. There you are. So that's where.
Suction.
Can you even see the muscles at the bottom there?
Suction लगा दो.
Yeah. So that's and if I can convince everyone, that's the sling. Give me the. Can anyone see that oblique muscle running?
Yes, we could, but Farooq, we're just going to go away for a few minutes and come back with you. You can start the myotomy. We'll join you with. There's something we just wanted to see.
Yeah, of course.
So I'll be with you.
So you see that limb? Yeah. So I access it from D2 a little bit deepward, going deep beyond the mass and then coming back. You can see that our needle is in the lymph node right now.
Yes.
Here, I have to use elevator to do my fanning technique because my wheel is all the way towards me right now. And so I'm using a little bit elevator, but look at, you see that I'm not coming out of that lymph node. I'm just bringing it back to the tip. And now I'm using a little bit wheel
and then going to this edge. Big wheel is all the way towards me, so I can't move it further. So I will pull the scope back a little bit, ask my tech to hold it for me. Isko hold kar lo yahan pe. And then I'll use a little bit elevator. You'll see how it's changing direction, and then going to this part of the lymph node. So I think we'll suction on it. Okay. So it's a small, very small area for fanning. So I'm using a suction on this to make sure that I get enough tissue on that. Any question on FNA, FNB?
Is this 22G?
G22, G22 acquired.
Okay.
I think this is good enough now. Okay. And I did it more than usual passes, which I do. One thing is a small area and the other is difficult to access. So I just want to make sure that I do enough passes back and forth that there is a tissue in there. And we got a really good tissue on the first one.
Have they made the slides?
He's working on that.
Okay.
So as soon as they come up.
So we'll come back to you when
Please. I just wanted to show that we got the lymph node.
And the lymph node doesn't look good.
No, it does not at all. Look at that. It does not look good. And there is other lymph nodes as well. Okay.
That's the thick muscles of the, that's what we need to get rid of. We will. So this is the, at this point, so we only cut the circular, this is the, that's the GOJ that we're going through here. That thick muscle is your GOJ. Huh? Gosh, this is so thick. Let's start layer by layer. ये साफ कर दें मुझे? Yes, sir. So you can see that is and now you're not getting that resistance everywhere. Are you guys with me? I just wanted to show something, Saad bhai.
We are back with you. Just give us 1 minute.
No, I only need 1 second. So
yeah,
that's
okay. We'll
that's
be
the
with you for
GOJ
1
fiber.
second. Go ahead.
Yeah.
You've
So
already started cutting.
So that's the GOJ fiber band right in front of me.
Yeah, we can see
Stomach
that.
beyond, and
Yeah.
this is and these are your longitudinal muscles above the GOJ. You don't have to cut. I only cut the circular muscles, and you can see the longitudinal start to spread already. That's it. Thank you. I just cut this back.
We will be back with you in just a minute. 2 minutes.
And this is by the.
Want to discuss
Blue.
the next case?
ओए मेरे कन्नाश म्यूजिक आ रहा है जोरदार.
Testing. Okay, we want to discuss the next case, and that's being taken into the next room. So this is a 19-year-old female patient with history of abdominal pain, nausea, and vomiting for the past 3 months. This patient has basically had recurrent abdominal pain. The symptoms were not being controlled. Ultimately, she was referred for a CT scan, and that showed pancreatic swelling predominantly in the region of the head and with mild peripancreatic fluid. An ERCP was attempted in a private hospital where the pancreatic duct was to be stented. However, that procedure failed, so a CBD stent was placed because they found the CBD to be dilated. Ultimately, she was referred to us. Endoscopically, there was an obvious bulge seen in the stomach along the lesser curvature, and along with that, there was an EUS was done. The EUS showed an 8 by 7 centimeter large anechoic cyst in the body and tail with some debris inside. So now the plan is drainage. Thank you.
I think we're okay here. I think ये इनकी ज़बान है जो हमने इनके मुंह में खुली छोड़ी हुई है.
Farooq, we are with you.
Okay, that's fine. So ये इनकी ज़बान को पीछे कीजिए. ये हाँ इनको पीछे करें. Otherwise the poor woman will wake up with a really sore tongue. हमने पहले उनका दांत तोड़ दिया है इंट्यूबेशन.
Farooq, आप जब muscles, when you're cutting muscles, do you come from below upwards or you go from above?
So the safest is always from proximal to distal. Always. And I didn't on this one because you could, if you remember, we really were getting quite a lot of resistance. This is not 1, this is type 2, this is, I can tell you that now. And I think we probably will end up doing, I've done about 3-4 centimeter myotomy, but my feeling is, so that's the incision where we walked in, as you can see, yeah, we now need to go here. And I think I'll probably will have to start from here, because these muscles, as you can see, are also, this woman will end up having good 8-9 centimeter myotomy. I've done the bottom one because if you remember my scope was stuck, the muscles were not letting it go. But that's what you really do here. यहाँ पे you can really do just a circular, and the longitudinal should open up by themselves. We are at 35. Yeah. Remember the GOJ was at 41. So we'll go, okay. Yeah. So very superficial longitudinal muscles we've cut there, and all we do here is just keep going deeper and deeper. That's all. I might actually come slightly above here as well, because these muscles are also very tight and holding us. So one thing that one be very careful, the other wall is a mucosal wall, so be extremely careful not to touch that. Can you see that fibrous band going across? Can everyone see that? This white fibrous band within the muscle. The muscle has gone, but the band hasn't. That, which is now on my tip. Can you see the right fiber band on its right hand side? Yeah. Bit stubborn, isn't it? It hasn't quite gone yet. Well, exactly. Now we're gone. Can you see that leather? On about 3 and 2 o'clock, you can see the 2 leather fiber. These are the fibrous bands. I can still see at the bottom, it's circular, it's not longitudinal. Or live in ime pata nahi kitna galan kiti janna. But that's okay, that's fine. Let's just carry on because I want this. Oh. She's okay? Okay, lovely. चले मेरे ख्याल अब हम इसको quickly ख़त्म करते हैं, otherwise the poor woman will be here for a long time. That's it. So now we are underneath. So it's easy for us now.
Here, when you go from that top towards bottom, better control, you have more space to work with. You can see the muscles right there. I think you trying to do a selective circular if possible.
That's right. That's right.
And also, you will see the longitudinal layer is very thin here. And sometimes, if the tunnel is not big enough, not enough space, and you do a circular, you may tear it. And it's okay. Not worry. So that happens sometimes. But I think he's trying to do very slowly, carefully, and not to damage the longitudinal layer.
Clean cut. Can you see that fibrous band again? Just about 6 o'clock there. Yeah, so that's what, so their muscle fibers become this fibrotic, this white fiber as you saw running across. Yeah, and that's another one.
And I think you're cleaning the knife, right?
Yes.
I think it needs there are still kind of circular
Yeah.
fibers there.
Yeah. We'll come to this. साडा पानी ले गया कोई नहीं आगे
I think you need so here because the direction of the knife is upward and there is a space for it. I think the knife you have to know the length of the knife is 4.5 millimeters, certain knives are 2 millimeters, other are 1.5. So use a little bit longer knife in this. But he is bringing that enough of that to hook the muscle and be able to cut, be able to maneuver that around, and not if it's not too much out, that you are not going to have a control of it and not know where the distal tip of the knife is. This and which cautery you are using? It should pure cut, right?
No, it's we use forced coag at 60. I don't use cut cautery for any of the myotomies. Do you?
Is this the Irby or is this the?
No, Sadhvik, they had to change Irby to back to the Olympus.
Okay, so we are using the Olympus.
Well, the one that you normally use in your unit. Yeah.
This is the.
So we sometimes increase it to 70 or 80. Khalid, do you do myotomies with pure cut?
Yeah, so I think, that's what's happening. I think there's a lot of coag and it's not, that's why your knife is getting a tissue, burnt tissue on that. So I will increase the cut on that. So we're gonna, Farooq, we're gonna leave you for a few minutes and then we're gonna go to the other room. Can we switch it to?
Yeah,
Can
that's
you switch to the other fluoro room, please?
Oh my God, she has got really, really difficult. या तो ये इसकी ज़बान है.
It's a concept of slab safety concept, ठीक है ना? तो mucosa आप क्या कर रहे हैं इसमें? You are cutting the muscle. You are opening up all the way to the mediastinum, ठीक है? अगर आपके mucosal layer intact नहीं है, तो you just cause the perforation, basically. Because you are in submucosa, नीचे muscle है, ऊपर mucosal layer, ठीक है? Muscle तो आपने काटना ही है, ठीक है? अगर आपकी इंजरी mucosa की भी हो गई, तो it's a full perforation, ठीक है? Mucosa you want to protect at any cost because that is your protection which is going to cover and not let anything spill into the mediastinum. तो अगर उसको इंजरी हो गई तो फिर तो वो ओपन हो गया ना. हाँ, ये जो एंट्री है इसको हम क्लोज करते हैं. And Mustafa, we are with you.
Okay, thank you. So this is that young, did you hear the story, the young patient with a pseudocyst?
No, we did not hear the story.
Oh.
Oh, you did? Okay. Sorry.
Okay.
They did, I did not.
Okay.
So I'll let Dr. Saad take it up.
Okay,
Yeah,
so
go ahead.
young patient who had an attempted ERCP, you can see the pseudocyst in the posterior stomach, and we measured earlier, but it's over 7 centimeters.
Okay.
So the other question in my mind was, what is up with the pancreatic duct? So in these situations, time permitting, I'll try and see if I can study the PD via EUS, since we're there anyway. So here's the biliary stent hanging out, and what's interesting is, as you pull back, you see inflammatory changes, maybe a little collection right by the head of the pancreas too. And then when you put Doppler on, this is all blood flow, so this is not the duct. If I just increase my depth for a second, I'm going to turn off the Doppler. And here I have the stent as my marker for bile duct, even if I don't necessarily see the PD. But you can see what looks like the PD there. If I can just put my cursor on there. Right here. So that now looks like a vessel. So that's where you can get fooled. So we're just looking to see if we can see any of the ducts to study it prior to drainage. The drainage is going to happen regardless, but just to see what's going on. So I'm going to turn this off for a second. So here now, so there's my PD, and if I see my pancreatic duct there, if I go clockwise, I should expect to see my bile duct. Earlier what I was able to see was the biliary stent and then the PD. So there may be part of bile duct, but it's not convincing. But earlier we got a very nice view of the bile duct with the stent and then the PD. There's bile duct with a bit of stent, I think. But we could track the PD back from there. So this could be bile duct with stent in it. And then PD was, you could see below it. This is not the same as earlier. But anyhow, so once we had the PD in view, we tracked it back towards the collection right there. So I may have already fallen back. So you can see the duct becomes more dilated towards the body tail, and you can see the collection coming off to the left of it. So this basically, when it gets dilated here, you expect to see a leak in a stricture usually in these settings. What I wasn't able to demonstrate was nicely how the PD and the bile duct come together and excluding divisum. But we saw that earlier. So at this, irrespective of that, our goal here is to drain it. I don't know if there's a strong preference for plastic versus metal in this setting.
I'll have to get into this one, Mustafa. In our practice, we don't use lamps.
Right. So,
okay. But I think, I mean, I have no problems if you want to use it. Just also for everybody to see how easy it is to put lamps. But the problem here is that it's about $3,000 plus, and that versus plastic stent is really no comparison.
Right.
For us in a center where we are actually providing it without cost, even here we obviously, I mean, here I need to look at cost. I would rather benefit 10 patients. And for now, please clarify. I mean, Khalid and you both use, I know, mostly metallic or lamps. What is the evidence currently in the literature to say that putting plastic stents is actually harmful or not equally good to lamps? I know it's easier, I know the time and everything else, but what is your view about that?
No, I think what time has proven that in resource rich countries where lamps are done, it basically is more of a convenience issue. But when you come to countries where the resources are limited, they have shown that you can actually do all of the management, whether it's pseudocyst or necrosis, with plastic stents. And then when they've done randomized trials comparing the two, the only difference is convenience and duration of procedure. Outcomes are the same whether it's plastic versus metal. So when I asked the question, it wasn't what you would do in normal practice, but for this particular case today, I'm happy to do a plastic if that's the way we should be draining this. उनकी आवाज़ नहीं आ रही. We can't hear you.
Hear us now? Can you hear us?
I can hear you now, but I can't hear the discussion.
Okay.
I just need to be told what to do here.
Okay. So, Mustafa, while we're discussing this, what do you think about transampullary drainage? Because she's a young girl, we will have to put the plastic stents for life.
No, we would. No, I think the way I would approach this patient is drain this transgastric, and do an ERCP, pull out the biliary stent, look for PD. The question is, do you want to do that today versus another day? But oftentimes, if I have good access and drainage, I will move forward with ERCP in the same session.
Okay.
But again, I'll be guided by what.
So Mustafa, what I think you're absolutely right on that. We need to do both. But what I usually prefer is do one thing at a time. Let it decompress. You will have a better chance at getting a PD next time. And other thing is, once you have done a cyst gastrostomy, moving back and forth with the scope, you don't want to damage.
You can dislodge. I think the one thing is with lambs, you're not too worried about dislodging the stent. Doing a plastic drainage, one of my concerns would be that in the process of doing the ERCP, we could dislodge our plastic stents.
Yeah, exactly. So I think we'll just drain it. We still are struggling with we want a lambs or we want a plastic. So if you are hungry and want to get done early, lambs.
No, I'm hungry to do plastic because we don't do enough.
Okay.
And also, I think the right thing in this environment would be plastic.
Okay, let's do that then.
So, okay. इसको हटा दें ज़रा measurement के लिए. Okay, 91.6. Okay, so
another question is, would just like a PD stent because of communication with the PD, would that take care of this? Do you think so or no?
I think for this size, I would prefer not to, because the downside is that you get bacterial reflux through the stent and you can infect a pseudocyst.
And so that's what I don't think this is ever gonna be drained transpapillary.
Yeah,
this would not resolve with that. Transpapillary, very small cyst, clear-cut communication with the main PD, and those usually are after you do drainage. They decrease in size, but they're still annoying, causing symptoms to the patients. You want to put a pancreatic stent in. But you cannot treat this one with the transpapillary stent.
ERCP again, the two issues. Like the second session, same time, you're taking a slight risk in a patient that was obviously not easy, they could not get in. So you want to do one therapeutic procedure, relax, and then bring the patient again. So that would be my take. The other thing is we are doing ERCP also to prevent further attacks of pancreatitis. See, there's a dilated pancreatic duct. We don't know what the... So the cyst is not going to be really helped by putting a pancreatic stent. The recurrent pancreatitis or further issues may be helped by getting into it. So that's the division. But how long do you leave the plastic stents, Khalid? I know you don't, but we're talking about if we were to drain two plastic stents in this cyst, how long? So currently the recommendation is you don't take the stents out. Okay, just leave them. That's the advantage of plastic stents. Looking at the pancreatic duct, dilated pancreatic duct, the way the pancreatic duct was, I haven't seen the MRCP, but that's what. Yeah. 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 Then forget it. मुस्तफ़ा
Yes.
हम फारूक के पास थोड़ी देर जा रहे हैं जब आप पंक्चर करेंगे तो
Okay.
Are you ready to puncture?
I'm ready to puncture. You tell me.
Okay, then okay, fine. You go ahead.
Okay.
You go ahead and puncture, and then we'll just want to see what Farooq has done.
Yes, of course. So I just took a 19 gauge and we have a wire in there. So we're going to do what I plan to do is 19 gauge wire followed by a cystotome and then balloon dilate and put double pigtails in. So you can see the wire, the needle tip right there. And the goal is to just have a nice safe window, quick.
There's a question.
Yes.
Shazad is saying the solid component in the cyst. How do you quantify it and, you know?
I don't.
You don't?
I don't quantify it.
Okay.
I just get on with the drainage. If I've looked at it on CT and MRI, the drainage needs to be done. Yes, it's very dense looking, which makes me feel that a transpapillary drainage alone will not be enough. That's the main thing here.
So I tend to, if it's more than 50%, you know, so in my, what I've seen is that it is difficult to drain all of it with the plastic because you seem to have more necrotic tissue. And if cost is not an issue, then probably a LAMS. But if cost is, you know, just putting cost aside, if the patient just has a pseudocyst, then actually, even if you have a free LAMS, I wouldn't put it because, you know, just to reduce the...
Yeah, but the only question is how accurately can we quantify the percentage? I think that's been shown over and over that any modality, CT, MRI, EUS, you cannot accurately quantify. This, I think the reality of it is this history tells you. With patients with necrotizing pancreatitis, the history is different for the most part than patients with recurrent acute pancreatitis with a pseudocyst. I think if you have a patient who's in the hospital for 3 weeks, you can start thinking that's necrosis. If a patient was in for 2 days, 3 days, that's likely not necrosis. I honestly don't think that we have come far enough to be able to accurately quantify necrosis. I'm going to go ahead and puncture the collection now.
But I was just wondering.
Yes.
Even if this case was in the US, if you put a LAMS, and it's more than likely this patient has got disruption of the PD because the fluid is still significantly high and has not settled. Patient is quite symptomatic. So once the cavity collapses, how do you swap over to the plastic stents? Any tips or tricks? Or
so I think this is a loaded question. Disruption implying a connected duct with a leak, you don't care about plastics in the long term because you're going to hopefully get across and seal the leak with a transpapillary stent. If you think it's a true disconnection, that's a problem. There's some data to suggest that LAMS alone is enough, you don't need to do plastics. We tend to put in plastics and then try and sometimes remove the LAMS but without removing the plastic. That can work, but if it falls out, you don't have space to do that. In the interest of time, I'm just going to puncture, but feel free to ask questions. So I'm just looking, I looked with Doppler, hoping not to hit any vessels. And then we're just going to do one firm jab. We do have fluoro here, so we're going to use that to advance the wire. I can see it coming out, and you can see it's a bi-lobe type of a collection. So we're just going to make a few lobes. I don't know if you can see the fluoro image, but we're just making a few loops in there. Fluoro दिखा दें उन्हें. नहीं, उनके नहीं दिखा रहा. So now we're going to exchange. So we're going to start.
Can we go, Mustafa? We'll just while you're making the loops and getting ready,
please do.
We'll go to Farooq and just see what he's doing.
Sure.
Farooq, the room. Endo 2 maker.
That's a difficult thing. You could have given me easy, but you wouldn't.
Farooq, we are with you again. Farooq, can you hear us? उनको बता दें we are with them. Farooq.
Ji.
Farooq, we are with you.
So we're just going through myotomy slowly, really hard muscle. We've got about 10 minutes of myotomy left.
Okay. Pretty thick muscles.
I'm afraid so. These are just the so this is just the first circular layer. I'm afraid. And I think given her comorbidity, her weight loss, I'm just being extra careful here. Can you see this is just a superficial layer there? So by no means, so we've done this far, so we started myotomy from here, going. So here we are, we're just going, can you see the longitudinal fibers at the bottom and circular at the top, which we have cut through. Yeah? Very nice. We'll just continue our journey here.
Fluoro 1.
और एक्सरे एंड इसी का फ्लोरो दिखा दें.
फ्लोरो दिखाएं.
Mustafa, we are back with you.
Okay,
so
good.
We can see the wire placed there.
Yeah.
And how are you dilating it? Are you using the cystotome or do you prefer using Sohendra?
No, actually in the past we never had the 6 French cystotome in the US, but recently we got it. So I think nowadays in these situations I would do a cystotome just for safety.
Yeah, cystosome makes life very easy when you're doing cyst drainage or other EUS related procedures. I think cystotome makes it very easy. But you have the option, like somebody suggested, you can use the Sohendra stent retriever as well. And there are I know the Japanese don't use this, none of the diathermy related, cystotomes, etc. They use the cannula. That's a hard tip. What is
So you can.
Yeah.
And you can
so
see
they use these cannulas to actually go through. I find that very difficult.
You can see the tip of the cystotome.
I think, like Khalid was saying,
ऑडियो हमारा ऑडियो जा रहा है.
हमारा ऑडियो जा रहा है.
Okay. So we're gonna
So, yes, Mustafa, we are with you.
Okay, good. So you can see the tip of the cystotome, right, where the green arrow is pointing.
So, yes, we can see the...
And you can see the wire. So I'm just going to go ahead and cut through and hopefully get across. Didn't go that time. So we're going to try again. That नहीं हो रहा है. Effect 1 कर दें. Can it go down? 1, yeah. So we're going to try and do less cautery and more cut this time to see if that works. I don't expect this. Connected है कि नहीं? I would expect it to go though. I don't think it should be this difficult. Yes. So our cystotome isn't going. We're just double checking everything is okay settings wise. Endo view दिखाएं. You can see it's indenting but not necessarily going through. Exchange. I'm just going to change my angle a bit. Make sure I'm still in
Can you change the cystotome, please?
Okay.
Give Mustafa a new cystotome. Adil, नया cystotome दूसरा दे दें. There has to be a problem, otherwise it should go through very
exactly.
easily.
Exactly, exchange.
Mustafa, I'm sorry.
No problem.
I think we'll ask them to change the cystotome.
Okay, we're just exchanging.
Can we go back to Farooq, please? अभी इसमें time लगेगा.
Why?
फारूक,
जी,
हम आपके साथ दोबारा आ गए हैं and we can see you cutting the muscle. It's really thick muscle,
I'm
Farooq.
afraid so. I'm really
I
afraid.
am now feeling a little bad, although I'm very happy that it's you who's doing it.
Thank you.
Um, but but it's, you know, you've done it very effectively because it's very clean, and see he's going.
So layer by layer, you can see head space takes time. There's no need for us to be rushing through this. Tip in control, needle in control, and you just go ahead.
Lapse of concentration. You just need a lapse of, just a lapse of and you don't realize it is wrong. I'm not like Arun, so I think cutting this way. But you have this, you can see how safely and neatly he's cutting every muscle fiber. Not an easy poem by any means. Muscles are very thick, so it's difficult to cut it. While he's doing that, you can.
So that's the GOJ.
Testing. The next case is a 45-year-old female patient. She had dyspeptic symptoms, epigastric pain, and some weight loss as well, but not too significant. So basically she had an endoscopy, and that showed a lesion, a polyp in the proximal part of the stomach. She had a CT scan as well, and that showed a hypodense lesion in the same area, but there was no infiltration, there was no localized lymph nodes in the area. So right now we will be proceeding for its removal, and EUS of this patient was done. It seemed that the polyp was arising from the third layer of the stomach. Thank you.
This is a geogen muscle. It is right at the geogen. तो मैं इसको अपनी तरफ इसलिए खींच रहा हूँ इनमें, बिकॉज हम लोग म्यूकोजा के बहुत करीब हो जाते हैं ना. हाँ हाँ हाँ, that's very true. That's very true. I think we're done. Huh? Would you agree?
Farooq, that's been done very impressively.
I just wanted, yeah, there it is. So we just, so if you
and
saw,
now,
yeah, so I'm just going to cut this last fiber. And I just want trainees to know one thing. आप लोग देखो कि मेरे बिल्कुल ऊपर mucosa है. So what
yes,
I do,
we were watching this. Yes,
so
we are looking
I'll
at
actually, तो जब last fiber पे मैं पहुंचता हूँ, तो मैं इसको cap के अंदर ले लेता हूँ. That even if I slip, that might take me 2 more minutes, but that will prevent your patient having a pus. There we are, we're done now.
Well done, that was very well done.
All is gone through now.
Did you encounter any big vessels which we missed, or?
We did couple, but my team and the attendant was really very nice. They were on top, and they said, I think we should we should force-up it. Before I'd even thought of being hero, I said, okay, that's fine, that's all right. And that's what the team and the unit makes a difference in third space. So I did that for a reason. And now you can see we are completely free. This is full thickness, and you now see the serosa there. Yeah. Done, guys. There we are. So that.
So, are you done with the muscle? Almost? No.
Gee, I'll just take this fiber away and then be done.
Then you're done?
Yeah.
Okay, so would you be, once you've looked at it and you're about to close, can we come back to you if you let us know?
Yes, yes, please, please.
Okay,
Carry
so
on.
we're going to go to Khalid. Endoscopy. Khalid sahab ke room mein
This
chale
is just a
jaएं.
fiber which is still getting stuck.
ये लगा हुआ है? Saad bhai, can you see me? Can you hear me?
Khalid, we are with you.
Okay, I think my initial plan was that I will see if I need to do ESD of this. And we put this cap on, this a Fuji cap, small cap. I usually like to use Olympus cap, जो बड़ी होती है, उसमें view थोड़ा बड़ा होता है. This is, you can see, it's like a hood on there. It's a limited view, but this is really good for ESD. But looking at this polyp, it looks hyperplastic polyp, and I think I can easily take care of that with EMR. So we decided to do a EMR instead. इसको पकड़ना. So I have a needle in there, needle into the patient, निकालो, needle sugar. The way I inject is, I will hold get the needle in there, and I will touch the mucosa gently. इसको पकड़ना यहाँ पे. And I will ask Wasim to start injecting. Inject करना शुरू कर दो. जब वो inject कर रहा है तो I am pushing the needle in there. So the थोड़ा stop कर दो. So injection starts as soon as the needle is touching the mucosa, and some of the injection is going to go onto the surface initially, and then I push that needle in. As soon as that needle finds the submucosa, it would start lifting. You can poke it, you can puncture it and then start injecting, but if you are in a colon or if in the duodenum, there is always a risk of needle can go through the whole wall. So I usually, that's how I like to inject. Go ahead, inject karo aur thoda. And you can see the injection is nicely going in there. I will lift that towards the lumen with my big wheel and keep injecting, That's good. निकाल दो needle. So there is a term we use, it's called a dynamic injection. So in this one, you can see the injection is all around. What you can do is, like, if I have a needle right here in there, and I want the left side to lift, not the front, not the straight one, I want injection to go on the left side, I will, एक मिनट, let me demonstrate that. ठीक है, एक मिनट, needle into the patient. So, if I want I will go right here. If I hold करो इसको scope को, ठीक है. I will go in, start injecting slowly, थोड़ा सा, stop. So if I want, now if I inject it, it's going to lift completely what is in front of me. But if I want the right side to lift, I will lean towards the left side. Inject करो. ठीक. तो उसमें injection वो देख रहे हैं आप left की तरफ जा रहा है, ठीक है? Now stop. If I want the left side to lift, I will lean to the right. Inject करो. तो अब नीचे की तरफ जा रहा है वो injection. So this is called a dynamic injection. So a needle back. I think we have enough injection there. एक मिनट ठहर जो इस side पे. I think we have a good injection on there too. So that's good. So I think we'll go ahead and resect this. Stomach wall is quite thick, and keeping in mind this is a EGD scope. Your working channel on EGD scope is at more like at 7 o'clock position. And on colonoscope, it is more like at a 5 o'clock position. The colonoscope big wheel moving away from you provides you a really good bending of the scope downwards. EGD scope, on the other hand, provides you a good banding upwards. So you have to determine, like I use colonoscope all the time for duodenal polyps resection. For stomach, usually I can work with the EGD scope. It's not and I can use the big wheel, even though it does not give me too much flexion upwards. It's a limited like that here, but it gives you a really good approximation if the polyp is on the top. And it's a completely opposite of the colonoscope. That's how they have made these scopes. So here I think I'm going to be fine with the working channel at 7 o'clock position, because I feel like this is how much bending downwards I will need, and that should be good enough. And they're looking for a snare captivator 1.5 नहीं है, 1 छोटा होगा इसमें ना,
नहीं सही हो,
कौन सा वाला, चलो दे captivator 1 दे दो, मुझे देख लेते हैं, हाँ, let me see that. So I ideally would have used 1.5, so I can just take that in one piece, but I feel okay, 1.5 कौन सा वाला है, वो वाला दे दो, ठीक है, 1.5. For EMRs, my favorite snare is captivator, different sizes, mostly 1.5.
Khalid, can you just tell us why you prefer captivator versus standard snare?
Yeah, there are thick wire snares, thin wire snare, captivator. The wire thickness is 0.42 millimeter. Cook snare, wire thickness is 0.37 millimeter. Cook snare, oval snare. If I'm using an elevator for ampulectomy, I like to use that because it's a thin snare, one thing. I can maneuver it and bend it and move from one place to other place in spite of through the duodenoscope easier. But for captivator, it's a round snare. It's a little bit thick. If I do a EMR, I like that because it just one thing is I want a little bit thick snare because that will provide a little bit more cautery effect as compared to a thin snare, and also it gives a good approximation and tissue capture for me with that snare. So that's why for EMR I like that instead of a thin snare, oval snare. I like a round snare. Open करो इसको तो. So ये कौन सा वाला? ये convex था ना? Okay. ये नया वाला snare है या पुराना? ठीक है. Oh yeah, it opened up. So I think we're going to be okay with this. So you see the snare is open right there. I will try to bring this to the left side. इसको hold करो ज़रा scope को. ठीक है. यहाँ पे. And I will push that into the base of it. Hold करो इसको. ठीक है. थोड़ा सा push करके रखो. ठीक है. अब close करना शुरू कर दो. When he's closing, I am pushing the snare. Keep closing, keep closing, keep closing. आहिस्ता आहिस्ता. When जब snug हो जाए ना तो फिर stop कर. Came through? नहीं, एक मिनट. छोड़ दो आप बेटा. So you see that how I put that on 9 o'clock position. The reason for that was I want like this does not give a good approximation upwards with the wheel. What that is like a position to the downward side. So I put it on the side. That gives you a better control of it. And also, if the polyp is on the upper wall, this EGD scope works really well. Ready? ठीक है. इसमें what I'll do is like we're snugged in. ठीक है. Close और थोड़ा सा close कर लो. और आहिस्ता आहिस्ता जैसे ही करंट शुरू होगा ना करते जाओ. ठीक है. चलो come through it. Go 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 go. चलते जाओ. Good. So in stomach, what I do is I usually use a little bit blue paddle, and especially in hyperplastic polyps. The reason for that is they bleed. So I want to have a cautery effect on that. And that we had a good cautery effect on that. So that gives decreases the risk of bleeding. But I think we are fine here. This is all basically trauma around that from the snare. But I think we got the whole polyp there. I don't see anything left. And it looks hyperplastic. So I think we're going to be fine. I don't think we need to
Khalid,
do.
there's a question. Can you do this without the cap as well?
Yeah, you can. I like to do a cap. Cap gives me a really good control of moving it. Like अब मैंने इसको control करना है patient की movement है and the breathing, and I really want to stabilize it. I can use my cap, push against the surface, and you see that even though patient breathing, heart rate high, and I can really stabilize my space. I cannot do that without cap.
Thank you, Khalid. That was very well done. We'll move to Farooq because he's going to show us. I think he's almost done.
Okay. Are you okay? Thank you.
Oh, would you put clips here or not? Is the
No,
question.
not really. No. I don't think I need a clip on this one. It looks it's a hyperplastic. It might ooze a little bit, but this is not a bleeding, so I would not use.
Okay, if I'm live.
Okay. Thank you, Khalid. Thank you. Well done. We are Farooq.
Ji, are you guys live with me now?
We are. Audio wise, yes. Visually, we are not. So just give us 1 second.
That's okay, no problem. मैं सिर्फ एक चीज़ है जो ट्रेनीज को दिखाना चाह रहा हूँ, and then you can go back. अगर मेरी जैसे आपके पास मेरी स्क्रीन आ जाए.
Just yeah, we've got you.
नहीं नहीं मेरी खूबसूरती के अलावा हाँ ये good. So अब इसमें मैं जो दिखाना चाह रहा हूँ चीज़ आपको, so this is the incision. If trainees can see that, अगर मैं इस incision को follow करूँ, so that's where it meets. You can see that crest है. जो आपने पहला clip लगाना है, वो normal mucosa पे लगाना है, which is grabbed. So it will be here. जो थोड़ी सी गलती करते हैं, वो they try to get the clip on the last point of the line. Try not to do that. उसके दो फायदे. एक तो you know that distally this is all closed, and that's because once you start put the clips, you cannot really go back distal again to close the space if there is one. Secondly, ये आपके लिए it makes a fine zip line. जो ये वाला होता है, it pulls it together. So that's all. चले. Now you can go to another room. Open the clip, please. Move कीजिए. Okay. ये 16 है.
Yes, sir.
क्लोज करें, फायर करें. ओके, लवली. यार मेरा ख्याल है आप लोग अभी मुझे अगला भी 16 ही देगा नहीं, मज़ा नहीं आया ना ये जाता जाता हमें वहाँ ले which we wanted. चलिए 16 ही दे रहे हैं. तो 16 छोटा ही है. नहीं 2 hours 20 minutes. Gosh, this was difficult. ओपन करें, रोटेट करें, ओपन करें, फुल. अब रोटेट. बस स्टॉप. थैंक यू. कोई गल नहीं. चलिए क्लोज करें. फायर प्लीज. थैंक यू. 9 16 ही दे दें मुझे प्लीज. हैप्पी? ठीक लग रहा है ना? 16 ही दे दें प्लीज. 9. Anesthesia happy? She's okay? Thank you. नहीं ये जिस मेरी आदत है, I try to ask again and again. Oh no, that's absolutely fine. Please, you do what you need to do.